Ready to start, I believe. Welcome, everybody, to this Masterclass in PET Management and Diagnosis of Alzheimer's Disease. My name's Lee Johnston. I'm the Director of the Melbourne Brain Centre Imaging Unit, and we're delighted to have you join us today for this Lilly-sponsored Masterclass, perhaps the first of its kind in Australia. So, I'd like to start, as we start, by acknowledging the traditional owners of the land on which we meet today, the Wurundjeri Woiwurrung people of the Kulin Nations, and acknowledge their elders past, present and emerging. So it's a great pleasure to introduce our first speaker of the day, Professor Chris Rowe. So Chris is a neurologist and a nuclear medicine specialist at the Austin Health and a professor at the University of Melbourne. He's been the imaging leader of the AIBL study since 2006, and is the director of the Australian Dementia Network, or ADNeT as it's known, which is a national collaboration of 19 universities and research institutes. His research focus is PET imaging, brain imaging, and blood biomarkers for Alzheimer's disease to advance understanding of the disease, translate recent advances in diagnostics into clinical practice, and to facilitate prevention and treatment trials. So he has authored over 450 publications and is a highly cited researcher in the top 1% worldwide of neuroscience. And you could potentially think of no better speaker to talk to you about this topic today. So welcome, Chris, and over to you.
Welcome, everyone. Good to see you here in sunny Melbourne. Actually, it's not too bad today for Melbourne. So the title of this talk is Amyloid PET brain imaging, appropriate use and reading methods. But I will also talk a bit about FDG PET and a little bit about Tau PET, just to put it all into context, particularly as FDG PET is now being widely used for dementia diagnosis in Australia. The current Medicare statistics show that there are 17,500 FDG brain PETs being done per year in Australia. In fact, enough to get Medicare looking into why it's so popular. Bit of background. So, dementia. So to actually define what's causing dementia, and dementia itself is just a descriptive term for symptoms. So, dementia is when you're cognitively impaired to the point that you can no longer independently undertake all your usual activities of daily living. And it has a number of causes. The largest is Alzheimer's disease, accounting probably for between 60 and 80% of cases of dementia in Australia. Up until recent years, the diagnosis of dementia was based on clinical grounds. So you had to have some abnormalities on testing, progressive decline on history, and you had to have dementia. And if you fulfilled appropriate criteria, you're given a diagnosis of Alzheimer's disease with just an MRI or CT and some blood tests to exclude a few other things. Turns out that that diagnosis is wrong 30% of the time when you compare it to post-mortem or to even people with a diagnosis of Alzheimer's disease that then go on and have an amyloid PET. 30% will be negative on their amyloid PET. So things are changing. There's widespread recognition of the need for biomarkers or tests that show the pathology of Alzheimer's disease to better improve the diagnosis and make an earlier diagnosis, because the clinical criteria make you wait until you have dementia before you tell a patient they've got Alzheimer's disease. And before that, there's a phase called mild cognitive impairment, where people do have significant memory problems. They know it, their family knows it, their co-workers know it, but because they're able to use lists and other such aids to get by and continue what they're doing, they're not defined as having dementia. So you go and see a specialist with memory complaint, but you're still coping reasonably well with things. They say, yes, our testing shows you've got a memory complaint, you've got mild cognitive impairment. We'll see you in 18 months' time, and when you get dementia, we'll tell you you've got Alzheimer's disease. So that's unsatisfactory. So hence the need for biomarkers, not only for more accurate diagnosis, but for earlier diagnosis. An amyloid PET substantially increases diagnostic accuracy for Alzheimer's disease. I'll go into that in a bit more during the talk. We also now have the disease-modifying therapies that are emerging and are now approved in the United States, Japan, Korea, China, Israel and the UK, although they're not back in the European Union, and they're currently under review by the TGA here in Australia. And those disease-modifying therapies are monoclonal antibodies designed to remove amyloid plaque from the brain, and to qualify for those therapies, you've either got to have an amyloid scan or a lumbar puncture proving that you've got amyloid in the brain. You can also use the amyloid PET scan for looking at the effectiveness of the treatment, and with certain treatments it is recommended that after 12 months you have an amyloid scan to see if you've cleared your plaques and the treatment can be stopped. The US has approved several F18 amyloid PET agents. They did this actually back in 2013 to 2015. These include florbetaper, which is the Lilly product, initially developed by a company called Avid that Lilly then bought out, flutamidamol, which is a GE product, and florbetaben, which was initially a Bayer Sharing product but is now owned by Life Molecular Imaging. There are no amyloid tracers approved in Australia, but several centres offer the test for clinical use on a user pays basis. So we will offer it at Austin Health for $1,000. It's out of pocket, the patient's out of pocket $1,000. We're considerably cheaper because we use my research team to make the tracer at the same time as we're doing research studies. We use the excess to do some clinical studies. But if you were to buy a tracer commercially from Cyclotech, for example, the cost is going to be around $2,000 or so in total. The alternative to amyloid PET is to do a lumbar puncture and take CSF and send it off for analysis for amyloid beta 42 and for phospho-tau and tau. That can actually be done here at the Florey Institute. The charge for doing that analysis is $400, but then you've got to find somebody to do the lumbar puncture and you've got to pay for the transport of the CSF to Florey. So the overall cost can be over $1,000 in private practice by the time you've paid for somebody to do the lumbar puncture. Now, FDG PET is Medicare reimbursed. It has been since late 2021, and as I mentioned, there's now 17,500 FDG PETs being done per year to assist with the diagnosis of Alzheimer's disease. Here's the item number, 61560, and here's the descriptor. It says that FDG PET study of the brain performed for the diagnosis of Alzheimer's disease if a clinical evaluation of the patient by a specialist or in consultation with a specialist is equivocal. So a GP could order this if they've discussed the patient with a specialist, but that doesn't occur very often. Now, many diagnostic evaluations are equivocal. A really confident diagnosis of Alzheimer's disease when you first see a specialist is not common. The service must include quantitative comparison of the results of the study with the results of an FDG PET study of the normal brain from a reference database. So there are various reference databases that are built into most analysis systems. The first one developed was Neurostat 3D SSP. It's been available in the academic world now for 15 years or so. We use it at Austin Health, but there are databases that come with Siemens equipment and GE, etc. In fact, the GE one, Cortex ID, was actually derived from Neurostat. You can only do this service to which the item applies has not been performed on the patient in the previous 12 months. Okay, you can't do it more than once in a year, but why would you? If you're looking for change over time on an FDG PET, you've got to allow at least 18 months before you can clearly see a change. A service to which item 41402 applies, and that is brain SPECT, has not been performed on the patient in the previous 12 months for the diagnosis and management of Alzheimer's disease. So you can't do a PET and a SPECT in the same year. for the diagnosis of Alzheimer's disease. And you're limited to 3 of these FDG PETs in a lifetime, but that seems fair enough. I'm not sure why you'd want to be repeating it once you've made a diagnosis. Anyway, so the total Medicare rebate is not a lot for a PET scan. Basically, it was the SPECT fee. So hence it's $605, but then you get the extra $100 for doing the CT for attenuation correction. So FDG PET, a few slides on this. So these are the key areas that we look in for an FDG PET. These also happen to be key areas in which tau is deposited in Alzheimer's disease, and there's quite a strong correlation between hypometabolism on FDG PET and the presence of tau in the same areas. So the lateral parietal cortex, do you see my, yes you do, you can see my arrow. Lateral parietal cortex, lateral temporal cortex, bit of prefrontal. The posterior cingulate gyrus, and this is the cingulate gyrus running over the top of the corpus callosum. So you've got the posterior cingulate back here, the anterior cingulate up here. So it's this sort of mid to posterior area we're particularly interested in Alzheimer's disease. And the precuneus, which is the posterior medial part of the parietal cortex. And then separating that is the parieto-occipital sulcus. So behind this you've got the occipital lobe. So this sort of roughly triangular shaped area on the medial views is important. It's actually quite important in tau PET imaging for the reasons I've just explained. It's also one of the areas you find tau. Here's a normal brain PET. So basically everything should look pretty uniform. The whole cortex should look fairly uniform. The posterior cingulate, which is this little knobbin type thing here, should be the brightest thing on the slice. So here you can see it's the brightest thing on the slice. Here it's doing pretty well. It's sort of equal brightest here. Behind the posterior cingulate, you have the precuneus, and that should be pretty bright too. So this is a normal looking brain. People didn't used to appreciate posterior cingulate until Neurostat came along and it started showing this reduction in this area that visually was being missed by readers, because if it looks the same or similar to tissue around it, then you think, oh, that must be normal, but it's not. It actually should be bright. So if it's not bright, then there's some hypometabolism in that area. As we come down, we look at the lateral temporal cortex, all nice and uniform. The lateral temporal cortex usually is a little bit brighter than the medial temporal cortex in a normal person. We check out the subcortical regions, in other words, the basal ganglia and thalami, making sure there's no evidence of small strokes, no irregularity suggesting small vessel disease in those structures. And of course, we've looked at the lateral parietal cortex, and I sort of like to look down around this sort of level. So this sort of posterior part of the brain, bit of posterior cingulate, precuneus, lateral parietal, that's sort of an area that has a strong influence on my interpretation. And here's a normal Neurostat. You get a little bit of light blue here and there, but there's nothing in a pattern that suggests Alzheimer's disease. And it's the pattern of reduction that is just as important as the degree of reduction in tipping you off as to whether there's Alzheimer's disease present. And this shows nothing specific. In contrast, here is a typical Alzheimer's disease case. If you come on down the posterior cingulate, you might say, oh, well, there it is, but it's not the brightest thing on the slice. It's actually down. The precuneus cortex is down. The parietal cortex is down. The sensory motor strip is preserved. So primary cortex is preserved, both in FDG PET and on amyloid PET and on tau PET. They're areas of the brain that seem to be resistant to the Alzheimer's disease process. So the primary sensory motor cortex, the medial visual occipital cortex, and the cerebellar cortex don't have much Alzheimer's pathology, so they look relatively normal on scans, or negative on an amyloid scan and negative on a tau scan. And in an FDG PET, well, they stand out as prominent because the metabolism's still preserved there where it's gone down in the regions around it. And you can see the lateral temporal lobes are down, and in this case the medial temporal lobes are also a bit down. This is dementia with Lewy bodies. Now, this used to be stated as being the second most common cause of dementia. It's dropped because there's now a condition which I'll talk about in 2 slides' time called late, which is now appreciated in people over the age of 80 as being quite a common cause for an amnestic Alzheimer's appearing type dementia, but it's not Alzheimer's disease, it's a TDP43 problem. So dementia with Lewy bodies has dropped down to 3rd or 4th on the list. It's only about 3 to 5% of people with dementia have dementia with Lewy bodies. They have some characteristic clinical features. They have visual hallucinations, and they have Parkinson's disease, and they have REM sleep disorder where they kick and thrash and smash the wall during their dreams, and they lose their sense of smell. So this is what the PET scan looks like. It looks like an Alzheimer's scan with a reduction in the parietal and the precuneus, but there's relative preservation of the posterior cingulate. This is sometimes referred to as the cingulate island sign. And there's involvement of the occipital lobes. So the primary medial occipital cortex should be as bright as the basal ganglia. So here you can see there's definitely a reduction in the medial occipital cortex. So when you put this on Neurostat, you've got parietal reduction, but you've also got lateral occipital, and you've got medial occipital as well as the precuneus. But the posterior cingulate, which actually wraps a little bit underneath this and goes forward a bit, actually isn't showing up if you know where to look. There is one catch with dementia with Lewy bodies, though. You do get the same appearance in a variant of Alzheimer's disease called posterior cortical atrophy. So, posterior cortical atrophy is more common in females, or I should say DLB is much more common in males, along with Parkinson's disease. So I'm a little biased in my reporting. I look at the gender of the sex of the patient. If they're female, I'll often tip my report towards posterior cortical atrophy variant, and if they're male, I'll tip it towards DLB. But it depends on the referral. If they're saying this person's got Parkinsonism and some visual hallucinations, then obviously you go with DLB. Posterior cortical atrophy is sort of a presentation of Alzheimer's disease where the memory is not too bad, but the patient seems horribly confused, and they have a lot of visuospatial problems. So they keep crashing the car because they keep driving into walls and things like that. They can't read a book anymore because they can't track the words and they can't process the words. And they keep going to the optometrist saying, I need new glasses, I can't read. So that's the main differential diagnosis. There is also a differential diagnosis of somebody with AD and visual impairment causing reduction in medial occipital cortex. So our technologists, as a routine, take a history from the patient, tick a few boxes, and one of those boxes they have to tick is there significant visual impairment? And if there is, they put a brief description. And that helps us a bit with our interpretation. If we think, oh, this looks like typical AD, the referral sounds like AD, but there's a bit of medial occipital reduction, well, if they've got significant visual impairment, that explains it. And it's not DLB. Then this is a diagram that all the nuclear medicine physicians in my department keep close by, because it shows the patterns of hypometabolism for the specific types of dementia. So this is the strength of FDG PET. Its weakness is it's not as sensitive as amyloid PET, particularly in mild cognitive impairment, but the strength is it can show you other dementias, not just Alzheimer's disease. So we've got typical Alzheimer's disease at the top with parieto-temporal reduction in the lateral views, bit of frontal reduction, sparing of the sensory motor cortex. These are Z-scores of how abnormal the scan is, and it's black, there's no reduction in that region. Medial temporal region, you've got the posterior cingulate, and you've got the precuneus. Some people with dementia initially present with language problems. They're called primary progressive aphasia. So this is when the language comes before the memory problems. And there's three causes of that. One is a variant of Alzheimer's disease called logopenic aphasia. They do get memory problems, not all that long after the speech problems develop. So if you give them a long sentence to repeat, and one typical sentence used by certain clinicians is, the emperor's jewel, the emperor's crown contained a rare jewel, and you get them to repeat it, and they can't, because by the time they've gotten halfway through, really they've forgotten the end of the sentence. Whereas some of these other presentations of primary progressive aphasia, the memory's quite intact and the repetition's intact, and they can say it back to you. So that's a simple way of, in somebody presenting with a progressive decline in their language function, with hesitancy getting out words, they're starting to find conversations difficult, they might know what they want to say, but the words won't come. Well, if you get them to repeat that simple sentence, it can help you tease out the Alzheimer's disease variant from the others. On FDG PET, it looks like Alzheimer's disease, but it's predominantly in the left hemisphere, which is your verbal hemisphere. Dementia with Lewy bodies we've looked at. It's got the occipital lobe involvement. Behavioural subtype of frontotemporal dementia shows frontal reduction. Also there's reduction along the insular cortex. Now this is largely hidden in these displays because it's sitting in there overlapped by the temporal lobes, but you can often see it as a bit of a rim where the Sylvian fissure is, because there's some atrophy and hypometabolism in that area. And they actually get anterior cingulate cortex involvement. This is the anterior cingulate here. And they get anterior striatum or caudate nucleus involvement. So this is a full hand of the findings you find in behavioural variant frontotemporal dementia. This is the classic FTD that people think about. These people are disinhibited. They lose their empathy. Their partner might fall down and break their leg, and they look at them and they're not concerned and they don't offer any help. And they become apathetic as well. They just want to sit in front of the television playing video games all day. So that's the pattern on FDG PET. Progressive non-fluent aphasia subtype of FTD is another one of these primary progressive aphasias. They actually look and sound pretty similar to this logopenic variant of Alzheimer's disease. They can repeat that sentence, and when you do the PET scan, you see the hypometabolism is in the dorsal left frontal lobe, and this is Broca's area. It's been known for a long time if you have a stroke in that area, you get expressive dysphasia. You can't get the words out, you struggle and battle to get, it's an effortful speech, and that's what these people look like. Then there's a third primary progressive aphasia, and this one is a bit different. These people are quite fluent, but they can hold a superficial conversation with you, but when you start digging in a bit, you realise they don't understand anything anymore. They've lost the meaning of words, they've lost the meaning. If you say, tell me about an elephant, and they'll go, elephant? And they've lost what an elephant is. Even show them a picture of an elephant, and they probably can't tell you what it is. So that's semantic dementia, and this affects the anterior left temporal lobe. Although there is a variant where it affects the anterior right temporal lobe, and in that variant people can't recognise faces. So you show them a picture of, used to be the Queen, but I'm not sure who would show now, and they wouldn't be able to name who it was. So, but there's an update now required to this, and this is because of late. Now I've mentioned late, limbic predominant age-related TDP43 encephalopathy. I should test everybody on that at the end of this talk. And the distribution of hypometabolism is different to FDG. And in fact, FDG PET is about the only test we've got for distinguishing Alzheimer's disease from late. Now, these people often do have quite severe hippocampal sclerosis on MRI, so that can tip you towards late. But in Alzheimer's disease, you get hippocampal sclerosis as well. In fact, in some of the FTDs, you get hippocampal sclerosis. But in late, you not only find severe hypometabolism in the medial temporal lobes, but you also find some changes going into the frontal cortex, particularly the orbitofrontal cortex. So there's a bit of reduction in the anterior pole as well. So it's sort of a anterior temporal lobe, orbitofrontal type picture. You may get posterior cingulate. You can see it here. There's some reduction in the posterior cingulate. These people have got severe amnestic problems, so their limbic memory circuit, which is the connections between the hippocampus and the posterior cingulate. Posterior cingulate's a very important integration processing centre for memory and other cognitive functions. So it's not surprising if their hippocampi are shot that their posterior cingulate activity is down. But what you don't see is the hypometabolism out in the lateral parietal temporal cortex, because in AD you've got tau in those areas causing direct damage to those areas. You don't get that in late. So in late it's more a purely amnestic presentation in somebody over the age of 80, and otherwise they're pretty intact. So it's a bit more benign than Alzheimer's disease, seems to have slower progression. Eventually their frontal lobes start getting affected and they become apathetic. So this is something quite useful for FDG PET, and I'm actually putting it in my reports not infrequently these days, because we get a lot of referrals in people over aged 80, and you look at the scan and there's not much going on in the temporoparietal regions, and posterior cingulate's down a bit, but, you know. And then you have a look at the medial temporal regions and they're clearly way down, and under those circumstances I'll say this is most likely late differential diagnosis, could be Alzheimer's disease, but it's more likely to be late. So these are the strengths of FDG PET. It's very sensitive in early onset Alzheimer's disease. That's onset before the age of 65. These people usually have a brain full of pathology when they present with their cognitive decline, lots of tau in the brain, so not surprisingly the FDG PET is very abnormal. So if you've got somebody sent in with query Alzheimer's disease under the age of 65, and it's not glaringly obvious on the FDG PET, then that diagnosis has to be reviewed. It's useful for both AD and non-AD dementias, as I've just pointed out. It's the only current test available for late, other than hippocampal atrophy, which is non-specific. So there's another feature in late I should point out. And you can actually, the Mayo Clinic does a bit of quantification to help them use FDG PET. In somebody with Alzheimer's disease, paradoxically, the lateral temporal cortex goes down more than the medial temporal cortex. Even though you associate Alzheimer's disease with hippocampal atrophy and memory problems, the hypometabolism is worse in the lateral temporal lobes than it is in the medial temporal lobes quite often. Not always, but quite often. Whereas in late, the lateral temporal cortex, it's not full of tau, it's relatively intact, but the medial temporal lobes have been destroyed by the TDP43. So if you do a ratio of either lateral or inferior temporal cortex to medial temporal cortex, the ratio is quite different in Alzheimer's disease to late. So if you want to do some quantification, you can, to help you further. The other thing about FDG PET is you can get an idea there's multiple pathologies present. You can see small defects in the basal ganglia telling you you're dealing with a vascular component. There's at least a vascular contribution to what's going on, or maybe even the small stroke that could have been missed by other investigations. Occasionally I'll say this person has features of both late and Alzheimer's disease, because they do have significant lateral parietal temporal reduction, but they've got profound medial temporal reduction. And we know that mixed dementia, unfortunately, is very common over the age of 80, most people have mixed dementia. They have more than one process going on at once. But there are limitations of FDG PET. Firstly, the hypometabolism does reflect the clinical deficits, so the findings may be subtle in mild cognitive impairment. Mixed clinical features are often associated with mixed FDG features. So if the referral comes in saying this person's got some frontal features but also memory, is this FTD or is this AD? Well, unfortunately, you might find both AD and frontal hypometabolism on your scan, and there's nothing worse than sending out a report that says exactly what, just repeats the question that the referring clinician asked and saying, well, it could be FTD, it could be AD. Under those circumstances, if you've got definite AD features, I say it's frontal variant of AD because there is a frontal variant of AD, and in some cases, frontal involvement is quite profound in Alzheimer's disease. And as you'll see on the amyloid and tau scans, there's a lot of amyloid in the frontal lobes, and in the more advanced cases, you'll see tau in the frontal lobes as well. FDG PET findings are less clear in the very elderly. Two reasons: they've probably got less cognitive reserve, so they become symptomatic with lesser degrees of pathology, but also they're more likely to have mixed dementia, so multiple processes going on. But if you keep late in mind, and you can actually turn this into a bit of a strength in your reports, rather than saying, oh, there's mild changes, it's all very non-specific, you can start actually saying, this looks like mixed dementia. There are some features of Alzheimer's disease, but there's some features of late, and there may be a little bit of vascular change as well. And then you come out sounding intelligent. And that's the big trick in your reports, is to make your conclusions sound intelligent. The sensitivity and specificity of FDG PET's about 85 and 80% respectively, so they're not always right. So that brings us to biomarkers for Alzheimer's disease. So 20 years since we did our first amyloid PET here in Melbourne, and that's when this technology became available. We got onto it as soon as it was available. And I think it's time we had a party to celebrate 20 years of amyloid PET. Tau PET is more recent. The first decent tracer for that came out in about 2013. We've been doing a bit with it since then, and then a lot with it since 2018. The reason for amyloid being targeted successfully earlier is it's extracellular. The amyloid plaques are outside of the cells. So you just have to get your tracer over past the blood-brain barrier, and there were lots of dyes that could be modified, and that's how these tracers were developed. The dyes that pathologists had been using on post-mortem tissue, which would find the plaques, stick to them, and fluoresce when you shine them under UV light. Those dyes were modified and initially labelled with carbon-11, that was PIB. But for tau, you've actually got to get into the cell, because the neurofibrillary tangles, they take up less mass, and so there's less of it, so to speak, and they're inside cells, so harder to get at. But that was successfully overcome. Initially a compound developed by Siemens, and then Siemens said, well, we're not in the tracer business, and they sold it to Avid and Lilly. So it became the Lilly tracer that's now known as fluortaucipir. And that actually has been FDA approved. Now, based on the various research done with amyloid PET, the criteria for diagnosing Alzheimer's disease, these are the sort of gold standard criteria. There's now objective episodic memory impairment, and that means word list recall, basically. You give people either a story to recall or a list of words to recall, and that's episodic memory. So they perform badly on that, and they've got a positive biomarker. It might be CSF or amyloid PET. Under those circumstances, you can make a diagnosis of Alzheimer's disease before they get to the dementia phase. You call it prodromal Alzheimer's disease, if they as yet do not have dementia, or mild cognitive impairment due to Alzheimer's disease. Various people like to call it one or the other. So amyloid PET, as I've said, has been around now, and in fact it was way back in 2013 that the Alzheimer's Association of the Society of Nuclear Medicine came up with appropriate use criteria. Basically, these are early onset dementia, so people under the age of 65. People at this age often have atypical features and get diagnosed with a psychiatric disorder. There's a lot of anxiety, there's depression, there may be some behavioural changes, and they often get shipped off to a psychiatrist because nobody thinks about dementia in a 58-year-old. And the diagnosis gets delayed as well because people don't want to make a diagnosis of a fatal condition in a relatively young person. So amyloid PET can conclusively make the diagnosis in this age group, so it's an appropriate use. And of course it has major impact on the patient, their employment and family, etc. So you want to get the diagnosis right. Mild cognitive impairment. Well, you can have mild cognitive impairment to a lot of reasons. You can just be having a bad day at the office when you're being tested. You could be staring out the window or distracted or upset about something you just heard. Or you could be depressed, just a very anxious person. You could be developing some other sort of dementia. You could have some vascular cognitive impairment. In fact, it turns out that only about 50% of people who get a label of mild cognitive impairment progress on to dementia. In those cases, it's mostly Alzheimer's disease, but not all of them. So if you have somebody with MCID, MCI, and they want a diagnosis, then amyloid PET at that stage can be very useful. And then dementia of uncertain cause after expert assessment is the third indication. Now, this is not uncommon. As I've mentioned, clinical diagnosis is somewhat unreliable, and patients can have various features that can throw a spanner in the works when trying to make a confident diagnosis. And now there's the new indication, which is screening people for suitability for anti-amyloid monoclonal treatments and to assess when to stop their amyloid therapy if you're going to go down that road. Okay, amyloid PET imaging, a few comments to begin with. Flobeta, which was the first FDA-approved tracer, the one from Lilly, firstly the FDA made them all do a correlation to post-mortem. So they had to find people who were going to die within 6 to 12 months, who were happy to have a scan, or couldn't refuse having a scan, might be another way of putting it, and then donate their brain after they died. So it wasn't so hard. We actually helped in a couple of these, and it was very difficult to get people without advanced Alzheimer's disease. Families of people with advanced Alzheimer's disease in nursing homes were happy to donate mum or dad's brain to research and let us bring them in for a scan. But trying to find normal people who are going to donate their brain, who are dying, and we're going to have to have a scan and donate their brain to research, turned out to be very tricky. But anyway, we got there in the end, and so did the various companies. And as I'll show you in a minute, they did quite well against pathological diagnosis of Alzheimer's disease, over 90% specificity and sensitivity. And then the companies were also told by the FDA they had to put reading programs out. So they've each got their own online reading program, and I'll give you the details of those towards the end of this talk. So with Flobeta, they decided best read with a black brain on a white background, so inverted grayscale. Flobeta then decided to be different, so they went for a white brain on a black background. Now, colour scales are easier if they work. They don't work so well on Flobeta and Flobeta because those traces are don't bind as tightly as well to amyloid as flutamidazole, NAV and PIB. So if you put a floor-beta-per or a floor-beta-ben scan into a colour scale, it'll often look like you're just looking at white matter, because the binding in white matter is more intense than the binding in the cortex, even when somebody's got amyloid present. If you flip it over and look in a grey scale, then you can sort of get a better judgment. Oh, hang on, this is blurring the white matter pattern a bit. There's something not quite right out in the cortex relative to the cerebellar cortex. I think there is some amyloid there, and you call it positive. So that's one of the reasons that it's either inverted grayscale or grayscale for floor-beta-per and floor-beta-ben. But for flutamidamol, NAV4694 and PIB, they're much easier to read in a colour scale, because then you don't have to do this fancy balancing it against white matter. You can just look and you can see there's red in the cortex, for example. I'll show you examples. You'll get the hang of it, because I'm going to show you lots of cases both ways. In reality, all traces can be read in grayscale, but reading PIB and NAV in grayscale is actually a little bit confusing, because there's less non-specific white matter binding. If you're judging the grey matter against the white matter binding, it actually then becomes a little harder to do. So just do it in colour and look for the cortex. So the better the tracer, the harder they are to read if you use this standard approach to black and white. So here's PIB. There's some non-specific white matter binding in the normal patient on the left, brainstem or midbrain brainstem, cerebellar white matter, but there's no binding in the cerebellar cortex. And throughout the brain, there's just hemispheric white matter, but nothing out at the cortex. Amyloid positive, well, an AD patient here on the right, bingo, you're going right out to the cortex. You're not actually seeing the white matter at all, because the binding to the amyloid's so avid that you're getting a nice strong signal from the amyloid in the cortex. And this is the typical distribution. You see a lot in the frontal lobe. You see it in the posterior cingulate precuneus area. You can see that there. You tend to see a fair bit out in the lateral parietal, though on this slice you're not seeing much. And you can also see it in the striatum and lateral temporal regions. This is a paper we put out quite some time ago now, when we looked at different causes of dementia with PIB. And on the right are patients with frontotemporal dementia. On the left are healthy controls. DLB is dementia with Lewy bodies. You can see the pattern in DLB is the same as the pattern in Alzheimer's disease, so it's not a great test for distinguishing DLB from AD, but it is a fantastic test in distinguishing AD from FTD. There was an application put in for funding of amyloid PET to Medicare in the United States a few years back, and this is before the monoclonal antibodies were available. And they said, it's $5,000 for one of these tests in the United States, and we need some evidence, said Medicare, that it has an impact on patients. So they did this study called IDEAS, and Medicare funded 18,000 scans done for clinical practice, as long as data was collected on the impact. And basically, it confirmed what we've been saying, that the clinical diagnosis of AD was pretty off, because the pre-PET diagnosis of AD, only 60% of people supposedly with a diagnosis of AD had a positive amyloid PET. And people were told they had something other than Alzheimer's disease, 55% had a positive amyloid PET. The scan was done, and the patients with a positive scan, the rate of AD diagnosis increased from 78% to 95%. And in patients with a negative scan, the rate of AD diagnosis decreased from 73% to 15%. So the clinicians put a lot of weight onto the amyloid PET scan. Despite that, Medicare decided not to fund it anyway. And it's only since last year when lecanemab was approved by the FDA for treatment of Alzheimer's disease that Medicare simultaneously approved a rebate in the US for amyloid PET. So it now is funded in the United States by Medicare and by private insurance companies, although there are still impediments to getting an amyloid PET in the US. The private insurance companies require pre-approvals for expensive investigations. They brought this in for myocardial perfusion imaging 15 years ago and basically reduced myocardial perfusion scan numbers by 70% overnight. That you actually have to write in or put in an application, maybe you do it online, to the local insurance company representative, and they have to check and come back giving you permission to do that test before they'll pay for it. That does introduce quite a delay. So what we're finding in the United States, that there's a lot of lumbar puncture being done because it's faster, quicker and easier for the clinicians to get a lumbar puncture to prove the diagnosis. In Japan, where they do reimburse for amyloid PET now, and they don't have to go through the rigmarole, 99% of people are having an amyloid PET scan, not a lumbar puncture. If we can get a Medicare reimbursement in Australia, then we won't have the American problems, and I think amyloid PET would definitely be the preferred option to Australian patients over a lumbar puncture. Okay, so we've been doing PETs, as I mentioned, since 2004. We were doing them serially in people in the AIBL study of ageing. So this was a big paper we put out in Lancet Neurology in 2013, documenting the rate of accumulation of amyloid. And it confirmed what people had been stating theoretically based on cross-sectional data. We had real longitudinal data and confirmed that amyloid accumulation is a slow process occurring at about 4% per year over 30 years before you get up to the typical level you find in a patient with mild Alzheimer's disease. And in fact, we can pick it up on amyloid PET 20 years before they get to that level. And if you do a bit of projection, there's another 10 years which they drop below the PET detection threshold, although it does depend on how good your PET scanner is and your tracer is. I think we're actually moving that threshold for PET detection significantly to the left now. Anyway, the total projection turned out to be 30 years of accumulation of amyloid before you were at the mild dementia phase. So this gives us a big window for early intervention, and we now are running trials around the world, including in Australia, of giving anti-amyloid antibodies in people while they're asymptomatic, but they have a positive amyloid PET scan. So that is good, but it does complicate things a bit, because if you look at cognitively normal elderly individuals, few of them, or quite a few of them, depending on their age, will have amyloid on a PET scan. So if you're in your 60s, 10% of the general population will have a positive amyloid scan, but if you're in your 80s, it's 50%. Now this curve actually precedes the curve of Alzheimer's disease dementia by about 15 years. So these people, if they live long enough, they're on the path, but they may be asymptomatic at the time you're scanning. Fortunately, most of them have low levels of amyloid. Very few have high amyloid levels who are clinically intact. But it is something to keep in mind that you may find a bit of amyloid in someone, but it may be irrelevant to their reason for presenting, because they may have another reason that they've got cognitive impairment and they're developing Alzheimer's disease, but they're way back at the beginning and it's not the cause of their cognitive impairment at the time you see them. So if you're reporting mildly positive scans, they're likely incidental. And that's what I say on my reports. I can see a little bit of amyloid, but it's mild and it's unlikely to be sufficient to contribute to their cognitive problems. Quantitation is becoming more important, particularly when deciding when to treat and when not to treat people. And we came up with a standardised scale back in, it's been a few years now. It's called the Centiloid scale. It's based on the Celsius scale, but instead of freezing water and boiling water at 0 and 100, 0 is what you find on an amyloid scan in young, healthy people who obviously don't have amyloid, and 100 is what you find in people with mild to moderate Alzheimer's disease. So we did scans in those groups. We developed an optimized region of interest. The red you can see here is one big volume of interest that covers all the areas of the brain where the areas where amyloid accumulates the most. So it's specific to the regions that you find amyloid. And we used a large cerebellar normalization region. So it gave you an SUVR, and then we had these SUVRs in the normal people and the SUVRs in the ADs, and then we linked them up into a 0 to 100 scale just using a linear equation. And so this was done for each of the traces. So there's a linear conversion scale for each of these SUVRs to give you a centiloid result. And Rob will be going into this in more detail. We do know now that centiloid results have been correlated with neuropathology and other aspects. So less than 15 centiloids, you've got no plaques. 15 to 24, you've got sparse plaques. Now, pathologists, when they look at a brain and they're deciding whether it's got Alzheimer's disease, they'll go, They'll look down the microscope at a few spots and they'll say, well, no plaques. Oh, sparse plaques. Or they'll say, moderate plaques. Or they'll say, frequent plaques. Moderate or frequent are required to meet the criteria for Alzheimer's disease, although that also requires tau. But if you've got less than moderate, then you don't have Alzheimer's disease. So you can have sparse plaques, but not meet neuropathological criteria for Alzheimer's disease. But once you get over 25, the postmortem studies have shown you'll have moderate or frequent plaques. But then the other kicker is that we now know that tau doesn't really appear much before 40 to 50 centiloids of amyloid. So amyloid comes first. It's been building up over many years. You get up to about 50 centiloids. So you've been building it up for about 12 years or so. That then seems to trigger something that makes tau appear and spread throughout the brain. So above 50, you're likely to have tau present as well, and therefore you'll meet what are called the neuropathological criteria for Alzheimer's disease, because you'll meet the criteria for both amyloid and tau. And it's above 50 when symptoms start to develop, because tau is the pathology that's correlated with symptoms. And at 100 you'll have the typical amount of amyloid in AD patients. So the level of amyloid does affect your risk of disease progression. Unfortunately, the FDA said, no, we just want a yes or no answer when you're reading scans. And so you're forced when you're reading to say yes or no. Now, that's a bit of a problem, because if you're just slightly above a threshold, firstly those thresholds with visual reading depend on the reader. Some are quite accurate at low amounts of amyloid, and some require quite a high amount of amyloid to really make a call of a positive scan. So we have shown, again from AIBL data, that if you have less than 15, well, you don't have plaques, and the risk of progressing from being normal to having mild cognitive impairment, in other words, abnormal results on memory testing, is very low over 7 years. If you've got a mild amount, which is the blue, so this is 25 to 50, or 26 to 50 centiloids, so it's what people would call a positive scan. But you can see they don't progress until 5 or 6 years. Now, remembering they're accumulating at 4% per year, so they've gone up 20 centiloids so they now are into that higher risk group, and they'll have some tau. But at the time you see them, they've got at least a 5, 6, 7 year prognosis. In fact, it's only 50% that have gone to MCI by 6 years. So, and that's a sudden drop at around 6 years. So you don't want to be inducing excessive anxiety, etc., by calling mildly positives too positive, so to speak. It's better to say it's mild and likely incidental than come out and say, well, you've got amyloid in the brain, you've got Alzheimer's disease. If they've got a lot of amyloid, so the orange is 50 to 100 and the red is over 100, then there's a 50% chance of having mild cognitive impairment by about 5 years. If you have mild cognitive impairment, then your risk of progression to the dementia phase of Alzheimer's disease, and this can be something called a clinical dementia rating, the CDR. A CDR of 0.5 is usually memory problems but not demented, and 1 is mild dementia. So this progression rate is also reflected by how much amyloid you have in the brain. So if you turn up with MCI, you have an amyloid PET scan, and it's green, which is, I think, less than 25 in this case, then your risk of progression to dementia is actually very low, and the patient should be reassured. If you've got 25 to 50, which is the blue line, your risk of progression, well, you've got a 50% chance of having dementia by about 6 or 7 years. But if you've got more than 50, then your risk of dementia is 50% in 3 years' time. So it has strong prognostic information. Again, because the level of amyloid tells you whether you're going to have tau or not. Now, carbon-11 PIB was the first amyloid tracer. Good tracer, but 20-minute half-life, not suitable for widespread use. Wasn't long before various companies developed fluorine-18 versions of amyloid tracer, and I've mentioned them, florbetaben, florbetaper. You can see they look very similar. They are developed by the same company, Avid, which was actually a spin-out company run by a neuropathologist from the University of Pennsylvania, who used some compounds that had been developed by a radiochemist there called Hank Kuhn. And they formed this company and commercialised florbetaben, which was AV1, which they then sold to Bayer, and then florbetaper, which was number 45, AV45 of the compounds they'd been developing, which later became the Lilly product. Flutometamol was developed from PIB. This was GE actually bought the rights to as many derivatives of PIB that they could think of from University of Pittsburgh, where PIB was developed. So flutometamol was the one they came up with. It has one downside, that it has quite intense white matter binding, but on the other hand, it's actually quite strongly binds to amyloid. Meanwhile, AstraZeneca in Sweden decided, well, we'd like our own amyloid tracer, and they found a combination of PIB that wasn't covered by the patent that GE had taken out, and happened to strike it lucky, and this became NAV4694 because it's the best tracer. In fact, it's even slightly better than PIB. Now, AstraZeneca got a new CEO, and like all CEOs, they have to change things, and they said, we don't want diagnostic tracers here, get rid of it. So they sold it to a small American company called NVIDIA. NVIDIA had a new CEO, and he said, we make detectors for sentinel node imaging, and it's a nice steady business, but we want to go bigger and bolder. We're going to make PET radio pharmaceuticals. So they bought it, and then realised they didn't have the resources or the money to develop it up to a commercial product. So after starting off with a bit of development, they then put it on the shelf where it sat. For about 7 years, we had access to it, and we were using it a lot. I hope I'm not boring you with these stories. Actually, I think they'll make it more interesting. And then along came a company called Savu, thought, we'll get the rights to this and develop it, because they were developing the MK, for Merck, they'd taken over the rights of MK6240, the Tau PET tracer, and are doing a good job with that. They've now sold it to Lantheus. So Lantheus now own NAV4694 and the MK tracer for Tau. Now Lantheus were in Australia. They're not in Australia at present, but they're big internationally. They're a big radiopharmaceutical supplier in Europe and the United States. So they are now controlling the provision of NAV and MK in Australia. Anyway, NAV is now going to the FDA for approval. That process has started. So hopefully we'll join florbetaben, florbetaper and flutamidamol as an FDA-approved tracer. And then we will work on Lantheus and our contacts to get it approved by the TGA here in Australia as well. I mentioned all these tracers had to go through neuropathological studies. Now, not big numbers, because finding these people wasn't easy, but nevertheless it was enough to convince the FDA that these tracers did what they said, and they were approved for assessing the presence of amyloid plaques. So basically, normal looks, this is a florbetaper scan on the left, and you can see white matter, but no cortex. And it means there's either sparse or no amyloid plaques. And it's got a very high negative predictive value for Alzheimer's disease. On the right is a clearly abnormal scan. You can see the cortex is filled in. You can't see the white matter anymore. It's all one big blur. This means there's moderate to frequent plaques, and it increases the likelihood of Alzheimer's disease. A little bit about Tau before we dive into amyloid PET cases. A few now, a lot more later on. AB1451 on the left is that Tau trace that was developed in 2013 by researchers at Siemens, and then was bought by Lilly and developed, and now has FDA approval by Lilly in the United States. It's called AB1451. It was another Avid developed compound. Sorry, no, it's not Avid developed, they bought it. Avid sort of bought it, and then Lilly bought them. Blah, blah. Fluortals here, and you can see a positive scan on the left and a negative scan on the right. The main problem with this tracer is there's quite a bit of uptake in the basal ganglia, and there's uptake in the choroid plexus, which is a bit of a nuisance when you're getting down into the medial temporal regions, because it's sitting right next to the hippocampus. But it's not a bad tracer. It does the job, so it's quite widely used. This was a series of tracers we worked with from a Japanese group, and GE got interested in them and bought the rights, and then unfortunately soon after it was realised that this tracer was mainly binding to MAO-B, not to Tau. And it turned out not to be a Tau tracer. Well, it had a little bit of binding to Tau, but most of this activity was MAO-B, and when you gave a MAO-B blocker, which they use for treating Parkinson's disease, this all disappeared. So this series of tracers died. This is the one that was developed by Merck, some radiochemists at Merck. Most of the companies decided they want their own tracer just for clinical trials. They're not developing them as diagnostics, but they want them to help them in their clinical trials. So Merck developed this and then said, but we don't want to work it up as a diagnostic, it's not our business. So along came Savu, bought it, worked it up, and now Lantheus have taken it over. The nice thing about this tracer is in a negative scan, it's really negative. There's no off-target binding. You do get a little bit of binding in the meninges around the edge of the brain, but you can deal with that. And the target to background ratio in a patient with positive Tau is really quite outstanding. These were the first 10 patients we scanned here back in 2018 with this tracer. They all had a clinical diagnosis of Alzheimer's disease, and they had positive amyloid PETs. But you'll see that 2 of them are negative on their Tau scan. See the distribution of Tau ranging, oops, I've lost my arrow. Oh. Somehow I've managed to lose my arrow. Well, you'll just have to take my word for it. This is curious. It's disappeared off some screen somewhere. On the left, we have a young person, early onset Alzheimer's disease. And as I mentioned, they have a brain full of pathology. This person's only 52, and yet their mini mental state score is still 29 out of 30. But their brain is chock full of tau. They've got it in their frontal cortex. You can see it's sparing the sensory motor cortex there. It's in their parietal cortex, it's in their lateral temporal cortex, and it's in their posterior cingulate precuneus area. Then we go along looking at the others. There's a fair bit of tau. It is asymmetric, it is patchy, not like amyloid, which seems to go everywhere. Well, in the usual areas it seems to go everywhere. Tau is much more patchy and idiosyncratic in its distribution. But we've got two cases. A 69-year-old with a mini mental state score of 24, this is the fourth from the left, who's got a negative scan. And so we scratched our heads, and then we had a close look at the MRI, and it showed bilateral infarcts in the posterior cerebellum. And this hadn't been reported. We also looked very closely, and there was a small occipital stroke in this person too, and this person had atrial fibrillation, so they were spraying off clots and having multiple strokes. This bilateral posterior cerebellar infarction entity actually has been recognised and is called the cerebellar cognitive affective syndrome. It does cause cognitive impairment. So this person's actually got a form of vascular dementia, but they've got some amyloid. Turns out it's incidental amyloid. If they live long enough, they'll develop Alzheimer's disease, but the main pathology in this person is their vascular disease. And on the far right, we have an 88-year-old with a mini mental state score of 25. Their tau PET's negative, but their MRI scan shows severe hippocampal atrophy. So this fits for late. So this person, again, at 88, had some incidental amyloid, not unexpected at that age, but their real pathology, their real pathological process and the reason for their presentation is late, not Alzheimer's disease. The distribution of tau is more variable than amyloid, as I've mentioned. There have been three variants described. The limbic predominant variant, where you can just see this little sort of hook shape on the sagittal view. We've labelled it the hook sign. And its uptake in the hippocampus and the amygdala and some other medial temporal structures. That's maybe just an early phase of people that then go on and develop tau in other areas, but don't know why I did that. But in some patients with dementia, that's all you find. Then there's hippocampal sparing, which is relatively rare, but it's not actually hippocampal sparing. There is tau in the hippocampus if you quantify it, but it's just less impressive than out in the neocortex, so it looks like there's not much there. And then the typical, where you can clearly see tau throughout the neocortex, but also in the medial temporal regions, which is a pity. So these two dots in the coronals are actually in the hippocampal amygdala areas. This is a study we did with the amount of amyloid present in centiloids on the x-axis, and we got all the individuals in the AIBL and ADNeT studies, and we added them up and we looked at their tau PET scans, and the tau PET didn't become positive basically until you had 50 to 60 centiloids worth of amyloid. So, strong evidence that the amyloid comes first, builds up. It's only when you get to a certain amount that tau becomes an important player and cognition starts to decline. And that's been since proven. This is a multi-centre study done through the Biofinders 1 and 2 studies. They're big studies from Sweden, the Amsterdam Alzheimer's disease Clinical Research Centre, and the AIBL study here in Melbourne and Perth, or in Melbourne actually. And again, this is now looking at amyloid and tau positive or negative. And if you're amyloid negative, tau negative, normal elderly person, your chance over 6 years of progression to mild cognitive impairment is minimal. If you're amyloid positive but tau negative, then your chance is low. So after 7 years, it's about 25-30% chance that you'll develop MCI. But if you're amyloid positive and tau positive, then your chance of developing MCI, if you've got lots of tau out in the neocortex, well, it's 50% at 2 years of having MCI. If it's just confined to the medial temporal regions, then it's 50% at about 4 years, or 3.5 years. So strong prognostic information from knowing your amyloid and tau status. And this has led to, yet again, a new revised diagnostic criteria for Alzheimer's disease, coming from the Alzheimer's Association Working Group, just been published this year. And there's a biological PET staging proposed. So if you've got amyloid but no tau, you have initial stage Alzheimer's disease. If you've got amyloid with tau limited to the medial temporal regions, you're called early stage. If you've got it out in the lateral neocortex but only to a moderate degree, you're called intermediate stage. And if you've got a brain full of tau, it's called advanced stage AD. And this seems to be important for prognosis, but it's also now emerged that it's important for response to anti-amyloid therapies. Because in the Lilly trial of donanemab, the people in the top 25% of tau in the brain had much less slowing of disease progression than those below it. And even Eisai have gone back and looked at their lecanemab trial. And they didn't have tau measures. So what they've done is they've used a threshold for amyloid where you're not likely to have much tau. And they've actually shown that if you've got 60 or less centiloids, your degree of slowing in decline increases from 27% in the overall tau population to 50% in those with less than 60 centiloids of amyloid. And that is becoming very significant. That's buying you years of quality of life, if that's the case. And in fact, there are some data showing when we do have tau in both trials, if you're amyloid positive but tau negative, you can actually stabilise and stop progression of disease. But that hasn't been tested yet. It's currently, as I said, under testing in these the big studies that are running with 4 years of treatment. But we may find, hopefully, that removing amyloid before the tau process kicks in stops you developing Alzheimer's disease. We're now in the process of standardising tau measures. We have the centiloid for amyloid, so center and loid from amyloid, and this is centau, as in cent and tau. And these are the regions. Because tau's a bit more regionally important, instead of having one overall universal region like you have in centiloids, there are different regions that will give you different measures, medial temporal tau versus neocortical tau, etc., because they have implications. This is that study from Eisai on their lecanemab, just showing that at 18 months, overall 27% less decline in the CDR sum of boxes, so that's the clinical dementia rating sum of boxes, and that's what got this study approved. But in those with less than 60 centiloids, it was 51% at 18 months, slowing in decline. And on the right are some extrapolations from Lilly showing the expected course of disease in green, depending on when you introduce therapy and get rid of the amyloid. And you can see up the top there, if you can get in early, you stabilise things. If you get in too far down the process of having symptomatic Alzheimer's disease, then your response is minimal. So this is the ideal patient for anti-amyloid therapy. This is a NAV amyloid scan showing the typical distribution of amyloid. And on the right is their MK tau PET scan. And there's a tiny bit of amyloid just there in the what's called the entorhinal cortex of the medial temporal lobes. So this is an A plus T medial temporal. So what we call, what was it? Initial early stage by the new biological staging system. Okay, getting down to how to do and read an amyloid scan. So these are the sort of official guidelines. NAV, the dose, it's generally been about 200 megabecquerels. Now, on the Siemens Vision 600, we're now down to 70 megabecquerels with this tracer. So we're talking a 2 millisievert PET scan. Flutamidamol, 185 megabecquerels, which is quite low. Why is that low? Well, this is another strange story that nobody knows, but we're amongst the first, we probably were the first to do whole body dosimetry on flutamidamol, and we came up with it was the same as everything else, like all F18 traces, they all end up to be about the same. But they got somebody in Europe to do it who came up with much worse dosimetry. So because of that, they had to use a much lower dose than anyone else specified. We thought it was a bit of a, well, we think they believe the wrong people. But anyway, so it's 185 for flutamidamol. For florbetaper, now this is an American dose, 370. Americans love their radiation. They always go for big doses in nuclear medicine compared to Europe or Australia. So they're still sitting on 10 millicuries, so 370. Florbetaben's a little bit lower, 300. And PIB has to be higher, 550, because of the 20-minute half-life. By the time you've waited 50 minutes, you've lost 75% of your activities. But because of that short half-life, the radiation dosimetry, in fact, even though you're giving a higher dose, is much lower than the F18 traces. Uptake times are optimal for NAV. Florbetaper and PIB is 50 minutes, so wait 50 minutes, then scan for 20 minutes. But with the newer cameras, if you're not lowering the dose, you can certainly lower the acquisition time. So you could scan from 50 to 60 or 60 or 55 to 65 and get a good quality scan. Because the beauty about amyloid imaging, you're not going for high resolution. You're going for a big regional target all over the brain, so to speak. Flutamidamol and florbetaben, you have to wait 90 minutes. This is because you've got to wait for the SUVR to reach equilibrium, so to get relatively constant. So with these traces, the kinetics are slower. So they're taking longer for that clearance from the cerebellum and the uptake in the brain to get to a sort of reasonably stable and give you a nice sort of flat line. And in fact, for flutamidamol, it actually never gets to a flat line. That just keeps going up. So the longer you wait to do a flutamidamol scan, the higher your SUVR, and if you're converting that to a centiloid, the higher your centiloid region will be. And that's why you have to do these scans, and particularly flutamidamol, at the same time every time. So you wait, just for practicality, you can't wait more than 90 minutes. So basically GE said, well, 90 minutes, do it then. Florbetaben does sort of level out at about 90 minutes. It happens to be around the same, and it is fairly flat after 90 minutes. Colour schemes I've mentioned, variants in those, so rainbow for NAV, rainbow for flute, rainbow for PIB, black on a white background for florbetaper, and white on a black background for florbetaben, but really for those two traces it makes no difference which one you use. And in fact I like to read all my black and whites as a white on a black on a white background. How do you set the colour scale? How do you slide it up to the right intensity? Cerebellar white matter works really well for NAV and for PIB. So I realised this back in the days of PIB. Slide it up till your rainbow colour scale is just hitting the max. You're just starting to see the max appear in cerebellar white matter, so just a few red dots. Same applies to NAV. For flute, the manufacturers say you should normalise to the POMS. Well, it's a bit the same as normalising to cerebellar white matter and other regions, but again, just get that white matter Well, if you're doing the cerebellar white matter with flute, you've actually got to make it all turn red. So unlike NAV and PIB, where you just want a little bit of red, with flute, it's got to be all red. So you've made the white matter your max. For beta per, says here, set your maximum intensity to the brightest region of brain uptake. So in a negative scan, that'll be your white matter in the cerebellum, but in a positive scan, they're suggesting you look out at the cortex as well. But in reality, it seems to be that most people just sort of slide it until they think that looks about right. So very subjective. So not too dark, not too light. For beta ben, white matter is the reference again, but that's slide it till it looks about right. So it's not very scientific. Positive scan criteria, well, cortical uptake in NAV and PIB. Flute, one region of cortical uptake. Or the striatum just showing clear uptake can be abnormal, but they say avoid using the occipital lobe. The reason for that is occasionally you get this hot spot in your occipital lobe. Nobody's quite sure what that means. It means there is amyloid there, but is it the same as the amyloid of Alzheimer's disease? So the occasional isolated, usually unilateral occipital pole hotspot is a bit of an unknown. For beta per, two regions positive, or one region where the grey matter is greater than the white matter. For beta ben, it's really one region of cortical uptake, again avoiding the occipital lobe. If you look at the literature on beta ben, they talk about this this strange scale of rating everything, and then getting it up, and basically it adds up to one positive region, you got a positive scan. But they make it sound fancy, and it's just, it's silly really. So that's how they're the criteria. So, how to read an amyloid PET with a colour scale. So I like rainbow scale, it's recommended for flute, NAV and PIB. However, rainbow scales vary. They're not all the same. They have different transition points across the different colours, and some, such as Siemens, decide to put white at the top instead of red. So you've got to find a rainbow scale you sort of like. It seems to give you a bit of contrast around where you want it, and then you get used to that and you live with that. So this rainbow colour scale came with Philips systems, but we've adapted it and transferred it to other systems as well, and I find it a very nice colour scale. And we set red in the cerebellum. So on the left you're seeing a few dots of red. On the right, the cerebellar white matter is not showing any red, so that needs to be cranked up a bit higher. As I mentioned, if it's flutamidamol, that whole cerebellar white matter has to be red. And this is what you're sort of looking for. On some axial views, here's 4 examples of varying amounts of amyloid or not. On the left is a negative scan. I've got a little arrow pointing to what is activity in the venous sinus. So there's the superior and inferior sagittal venous sinuses. One goes over the top of your brain, one goes over the inferior one goes over the top of your corpus callosum. They meet up, and then coming in from the side you have the transverse venous sinuses, and they all join up and go down through your jugular veins, internal jugular veins. If there's a bit of activity still in blood pool, you'll see this dot in the superior sagittal sinus. It's there anteriorly as well at the anterior end. As you've sliced through, you can see the 2 dots there. Anyway, so review the cerebellum first to confirm that you've got differentiation between grey and white matter. You should see it because you're not supposed to have amyloid in your cerebellar grey matter. So that should always be cold, and your white matter should also always show activity, which you've now set your colour scale on. You can use the cerebellar grey matter as an internal reference of what negative cortical appearance should be, and I'll show you some examples of that using coronal slices. Check the interhemispheric fissure, particularly in the occipital and frontal regions. Now this is the interhemispheric fissure, it's the gap between the hemispheres. It's not supposed to touch. So it can touch if you're appear to touch if you're slicing near the corpus callosum, which joins the hemispheres together because you're going through the white matter there in the middle. But anteriorly and posteriorly, you should have a gap between the hemispheres. That gap is bigger in older people than younger people, so there is just a little bit of a trap there. It's an important trap. Younger people tend to have more white matter, bigger looking white matter areas, and smaller fissure between the hemispheres. Don't mistake that for a positive scan. So keep in mind the age of the patient when you're reviewing a scan. In this next one, it's clearly abnormal. You've lost that gap. You've now got cortex, and this is cortex in the medial parietal region. So this is that precuneus area and posterior cingulate. The cortex is filled in, so you haven't got the fissure plus the cold grey matter to give you a nice white gap. Now all you've got between the hemispheres is a little slice of tentorium falx cerebri, sorry, the fibrous tissue that divides the hemisphere up there, and you can't see that given the resolution of the camera, so it looks like everything's now merged together. So this is mildly positive on a NAV scan. You can see things are touching, but you're not filling in the cortex with bright red activity. This one is moderately positive. You're now getting red. You've got frontal cortex, you've got posterior cingulate precuneus, a little bit of parietal. You can see there's some sparing of the sensory motor cortex, but it's not bright red. This is a typical AD patient here on the right. Things are now bright red. Lots of activity in the parietal cortex, posterior cingulate precuneus and frontal cortex. Still sparing sensory motor cortex. If you go through some of the courses online, they'll throw in some of these terms. This is radiographics, which is a reference material for radiologists from the RSNA, Radiological Society of North America. These are their examples of positive versus negative fluor beta Ben, remember white on a black background, and fluor beta per, which is black on a white background, but if you swap those colour scars, they'd look exactly the same. And here's flutamidamol. Notice in flute, you actually get a lot of white matter around the thalamic area, so it's quite normal to see these big red lumps in the middle of the brain, which are perithalamic white matter on a flutamidamol scan. Terminology that's used, looking for that gap between the hemispheres anteriorly, should be a diamond-shaped clear space. Looking for the white matter, cartoon hands, the fingers of white matter projecting out, which are then surrounded by the cortex, but there's nothing in the cortex, so you're just showing those fingers of white matter. Kissing hemispheres is a term that's thrown around when the hemispheres come together and start touching. Positive scan sign. Tree in winter, there's no leaves, so you're just seeing the branches. That's a negative scan. Tree in summer, all the cortex is filled in with trace out binding to amyloid, and it looks like there's trees on the leaf. Leaves on the tree. So tree in summer. So a few terminologies that people like to use. Here's a negative NAV scan, just running down. Again, there's a little bit of activity, just this tiny thing here, but it's not enough to distract you of being of any consequence. That's activity in the superior sagittal sulcus. Nice big gap between the hemispheres all the way down until you start coming to the corpus callosum. You're cutting through the corpus callosum. There's fingers going out towards the edge. There's clear cortex. It hasn't filled into a nice smooth appearance, which is what happens when the cortex takes up tracer. And down here in the cerebellum, there's no activity in cerebellar cortex, and you've got very nice contrast between white matter and cerebellar cortex. This is a mildly positive NAV scan. So you've got some coming together posteriorly initially, but then more here in this region. the interhemispheric fissures now being blurred out. With a bit of imagination, there's a little bit of activity going out to the edge here of the parietal cortex. A bit more imagination. Frontal cortex looking a bit smooth rather than just finger-like. But not a lot. It's not bright red as you expect to see in a positive NAV scan. So this is mildly positive. In fact, the Centiloid score on this one was only 24. Thresholds that are used around the world vary a bit, but they're either 20 or 25. We use 25. So this is sitting right on the borderline for what most people would call positive or a negative scan. And as I said, you can see sparse plaques below 25 centiloids. So this is an equivocal sort of result, one you don't want to play up too much. If you're going to say anything, you say there is evidence of a mild degree of amyloid binding, but the finding is insufficient to account for clinical decline or cognitive decline. In contrast to this one, now this is a typical positive NAV scan. It's in an older person, so you've still got a bit of a gap between the hemispheres here, but you can see the cortex in the parietal, the precuneus, is filled in with intense activity, and the frontal lobes, and you've got sparing of the sensory motor going down, lots of frontal, lots of posterior cingulate precuneus back here, parietal cortex, lateral temporal, and now we're seeing the anterior striatum, or the caudate nucleus, part of the basal ganglia, that show up positive with flute, PIB and NAV, but rarely with the other two traces, because these traces are more avid for amyloid, so they're picking up what is sort of more diffuse plaque in this part of the brain than the other traces. They're more sensitive, so they're showing more. And as you come down, lateral temporal, but here down in the cerebellum, again, nothing in the cerebellar grey matter. And the intensity is about right. You're just seeing a little bit of red. It's not like somebody's twisted the dial up too far and it's made everything go red. This is well set. This is a range of flutometamol scans showing a similar sort of thing with flutometamol. Negative scan on the left. Remember I mentioned you've got to make the entire cerebellar white matter go red, and at that you'll also see this prominent perithalamic white matter in a negative scan. But you've still got a good gap between the hemispheres, you've still got finger-like projections going all the way around, still got the tree in winter, not tree in summer, and you haven't smoothed out the edge of the brain because you've filled in the cortex. So that's a clearly negative scan. This one, it's sort of hinting that there's some activity in cortex generally, but you're still seeing the white matter pretty clearly. The intensity is right. There's probably a little bit of amyloid, but would probably still be read as a negative or equivocal, but I wouldn't put too much into that one. In this one, the hemisphere is closing up a bit, and you've got areas where there looks like there's definite parietal activity, some medial frontal here. The frontal lobes are showing activity out to the edge. There's a little bit back here in the temporal and even the medial occipital area. You've still got that perithalamic white matter activity showing up as the brightest thing in the slice or on the scan, but there are patchy areas of cortex coming up. So I'd call this a mild to moderate type scan. This one, colour setting's about right. Cortex is clearly filled in now around the frontal regions, lateral temporal, right out here to the parietal areas and in the medial precuneus type region. And if you look back here, if you're comparing uptake in the cerebellar cortex, especially on this side, the cerebellar and the lateral temporal lobe, clearly there's a huge difference. So this is a moderately positive scan, definite positive, enough to be accounting for causing symptoms. And then on the right, we have a typical strongly positive scan. Looks just like that NAV scan, got uptake in the striatum as well as throughout frontal, lateral, temporal, particularly intense uptake in the parietal and posterior cingulate regions here. This colour scale is going to white as it gets to maximum. And again, if you look at cerebellar grey matter versus cortical grey matter, huge difference. So strongly positive scan. I mentioned using that cerebellar grey matter as an internal control. So here we have a phlebitis per scan and a phlebitis ben scan, same sort of thing. Here's the white matter in the cerebellar cortex. Grey matter is negative. Compare that to the grey matter going up around the edge of the brain here. Clearly there's a big difference. There's binding in hemispheric grey matter. Same with this phlebitis ben scan. Nothing in the cerebellum. So if there was nothing in the hemispheric grey matter, it should show nothing, but instead you've filled in nice smooth edge because you've filled in all that activity in the cortex. So clearly both of these are strongly positive scans. And they don't knock you out like when you're looking at a strongly positive NAV scan. And we've certainly seen our referrers when we were doing some scans for various studies and showing that the memory clinic multidisciplinary meeting, it takes about one meeting before the geriatricians across the other side of the table are calling out whether it's positive or negative once you start sliding a piece of coloured paper over. But when you slide black and white over, they start scratching their heads, and I guess I cannot emphasise enough that the colour scales, if you've got a tracer that works well with colour, is so easy to read. Something else worth looking at on the with the black and white ones is the corpus callosum. It's all white matter, so it should have high uptake, and there shouldn't be any uptake in the brain around it. So you like to see a nice intact and clearly defined corpus callosum to help you be more confident you're looking at a negative scan. The other place is to look on this mid-sagittal slice. Remember I talked about a diamond back here on the neuroscience studies for FDG PET of hypometabolism involving the posterior cingulate and the precuneus. We also want to look in that area for uptake on a tau, on an amyloid scan. And the other area that often shows amyloid fairly early is in the orbitofrontal cortex. So in the mid-sagittal, look for the corpus callosum. If it's really clearly defined and there's no activity encroaching on it, you've got a negative scan. You have to be careful that your mid-sagittal slice is nice and straight though. If you take it on an angle and start cutting back into the white matter on one of the hemispheres, it's going to look like you've got posterior cingulate precuneus. Artefacts. Few artefacts. Meningiomas. For some reason, meningiomas seem to take up everything. And they take up amyloid and they take up tau traces brilliantly. Infarcts, prior hemorrhages, trauma might cause a defect in your scan because the brain's dead there and there doesn't seem to be any amyloid in dead brain. Normal pressure hydrocephalus is a bit of a tricky one. These are usually moderately positive because it seems that normal pressure hydrocephalus and amyloid go together to some degree. Whether it's fully blown Alzheimer's disease or whether it's just impaired clearance of amyloid that leads to a build-up and therefore amyloid plaques, not really quite sure, but often patients with normal pressure hydrocephalus will have some Alzheimer's type pathology. Severe atrophy. This was a problem in the phase 3 studies when we were pulling people out of nursing homes with terminal Alzheimer's disease. Their brains were so shrunken, they had so little cortex left that some of the scans just looked like fingers of white matter because the cortex had all disappeared. But at post-mortem, there was heaps of amyloid in what little residual grey matter there was. Fortunately, in clinical practice, we're not scanning these people. We don't scan people with incredibly advanced brain atrophy, so it's not really such an issue. Poor tracer quality or rapid metabolism results in vascular structures which can be a little bit prominent. I'll show you images next. Defluorination rarely occurs when we produce these traces, causes uptake in skull bone obviously. Patient movement, though, is one of concern. And Siemens system, we've got an experimental software motion correction system on the Siemens system here. And it does make a difference when patients have moved and you apply this very computer intensive motion correction algorithm to the image. They do sharpen up nicely. So when somebody moves, they can blur activity from the white matter into the grey matter and potentially give you a mildly positive scan when it's not actually mildly positive. So you do need your technologist to keep an eye on these people and to report if there's been any significant movement. And you do need to, and I think Rob will probably tell you a bit more, you do need to try and get good head fixation, but just as you do for an FDG brain PET. This is one of those prominent blood pool activity scans. So this is what I refer to as the superior sagittal sinus. It's full of venous blood. Inferior sagittal sinus, joining up through the straight sinus and then coming in from the sides. You've got the transverse sinuses. Then eventually it will go down the sigmoid sinus into the internal jugular vein. So if you've got activity sitting in these areas, you see the red spot. In this case, it's quite intense, anteriorly and positively, posteriorly. There's that inferior transverse sinus. These are the inferior sagittal sinus. These are the transverse sinuses, and here they are disappearing down into the jugular, and you get a whole lot of facial. Despite that, this is still a clearly negative scan. So you can read through these traces, and you just come across it every now and then. Some individuals are either slow or fast metabolizers. I'm not sure which of the tracer. When you repeat the scan, you get exactly the same result. But they're usually still interpretable. Amyloid negative dementias, well, when you do an amyloid scan and it comes back negative and you get a clinician phoning you up and say, hey, I'm sure this person's got Alzheimer's disease. What's going on? Your scan must be wrong. Well, you turn around and you say, no, they've probably got late. Or they could have dementia with Lewy bodies, 50% are amyloid negative. They could have a frontotemporal dementia. They could have progressive supranuclear palsy, which is more of a movement disorder presentation rather than a dementia. Likewise, corticobasal degeneration. And then pure vascular dementia by itself is actually quite rare. I've mentioned late, we've been through that before.
Right, so you're probably looking at all of those images, and with anyone that is thinking like, what can we do with computers? Is it possible to quantitate? And indeed, we're not trying to replace clinicians. That will never be the case. But however, it is very good to have an automated scoring system. And if only it was as simple as you might hope that it would be. Rob Williams is our lead Chief Nuclear Medicine Technologist here at the NBCIU, and he's going to talk to you today about how to quantitate PET scans and what to do to get to that point where you can actually make a reasonable computer-generated centiloid value from the scans.
Right. I want to talk to you a bit about how we quantify our amyloid scans, and that's actually quite important, and it's become more and more important when we discover what's happening. These are my disclosures. Now, before you go any further, all the nuclear medicine people here, that's your Attendo QR code. So if you can do that to get your CPD points, I'll leave that up for a second so you can do that. Still a few phones waggling around. Is that big enough? All right, good. Not working? Yeah, we'll just stick at the end. I'll pop up at the end and we can come along closer. Now, I guess the main motivation for quantitation and amyloid PET in general is the revolution that's come with amyloid therapies. Now, lots of you will have seen the press which said that the amyloid theory for Alzheimer's was wrong. There was lots of things in Australian media and international media saying it was wrong. And what was wrong was that they weren't doing PET scans and they weren't measuring them. If you don't do a biomarker of what you're trying to fix, then you will fail. Without the biomarker measures to see what dose, what patient, whether they really had the disease, whether they were giving the right dose and at the right time, your therapy will fail. So the new antibodies that are coming out to treat Alzheimer's disease really depend on PET scans so that we can identify the right patient. And as you saw with Chris's talk before, when nearly 50% of the clinical diagnoses were really quite wrong, without doing the PET scan or without measuring it, you can't tell whether someone's going to be effective. So the measurement's really critical because a lot of the therapeutic range is in measuring measurements required for that. So why do we quantify? Well, visual reporting is not quantitative. Therapies are typically planned at low levels of AD. They seem to work much better at the early stage of AD. And it's very hard to do that and read those. Unless you've got a Chris Rowe in your department, it's very hard to read these things. Even expert readers have trouble reading accurately these low levels of amyloid. In our A4 study, 23% of subjects were enrolled as having been positive, even though they had an amyloid score of below 25. And we've found that in other studies too, even with expert panels, they're not getting it right a large percentage of the time. They just don't have the skills that Chris has got. So that's why in virtually all the studies now, in all the therapeutic windows, they rely on centiloid numbers to determine the efficacy of therapy, whether someone's suitable, whether the therapy's been given to the right people, whether it's been given long enough, and when to stop the therapy. So it's important that we do that. And the visual-based reading, if you look on the left of the visual-based reading, is largely above the area where the therapeutic thresholds exist. So our amyloid imaging and measurement is not about diagnosing AD. It's about staging AD. It's about figuring out whether someone's at the right stage for a therapy. And the staging's, at a fairly low level. Lots of people can be symptomatic. If we take this as an amyloid A-beta pathology target, you can have MRI changes, you can have FDG changes. All of those changes will occur away from a therapeutic target, which is in the bullseye. FDG changes, again, too late. Visual reading, largely too late. Centiloid amyloid will give you a good score and narrow it down, but if you combine it with tau, you're really going to get people in the right therapy. So if you use conventional diagnosis, you're going to miss the target lots of the time. Lots of people just simply don't have AD at all, let alone the right level of AD. If you do FDG, again, it's going to be too late, mainly. FDG more closely aligns with tau because you're looking at pathological changes. So it's often too late if you're using FDG. FDG is all right for diagnosis, but it's going to miss the staging that's appropriate for therapy. Visually reported is going to miss a lot of people too. It's going to hit some people, but it's going to miss a lot of people. If you use centiloids, you're going to get better. And if you combine a centiloid amyloid plus a tau, you're really going to select everybody who really is going to benefit from these therapies. Now, in order to get a centiloid and then get a measurement, you've got to do your PET scan correctly. So you've got to do the QA of the instruments, you've got to get your timing exactly right, you've got to do good electronic record keeping to get that timing right. You've got to do some other things like keeping your reference regions sacrosanct, so keeping the cerebellum away from the edge of your field of view so that you get a good image. You've got to minimise movement, and you've got to do your attenuation correction properly. So let's look at timing, and timing is critical, and this is what happens wrong. In this paper, they looked at starting the scanner 5 minutes, 10 minutes early, or late. And they got quite dramatic changes in centiloid numbers simply by starting it too late. And even in the same subject, particularly in high centiloid numbers, that change in timing made a big difference, and it's not very consistent. it affects that change in timing affects different levels of amyloid at different amounts. It's very hard to predict for that reason. So you really must start the scan at the right time. What we do is we have an electronic trigger that triggers at the time of the injection. We display a countdown timer on our scanner, and I press start, pop them on the bed 5 minutes beforehand, and press start at this second that it's 90 minutes or 50 minutes or whatever the appropriate time is. I know a lot of the guidelines say, plus or minus 5 minutes. Let's try and make it to the second if you can, or certainly within a minute, so that you're going to get a reliable centiloid number. Particularly when you're giving people therapy, you want to know when to stop it. So you're going to compare the same patient before and after therapy if you're getting that timing exactly right. And the effect and timing varies between different reference regions. The official centiloid reference regions often cover the whole cerebellum, but depending on which reference region, that's also going to affect this timing as well, and often makes very differences. But there's very few reference regions that are indifferent to the timing, and those that aren't really used widely. So get your timing right. The other thing is to make sure, like you're doing in oncology, make sure that you've got your QA correct. And that means your daily QA of the machine, doing your cross-calibration between FTG and your gallium phantom. I do it every day. I know lots of places do it quarterly and so on. It shouldn't drift that much, but there's no harm in setting a scanner up and doing that quality control. Making sure you dose calibrate. If your SUV is not right, then your SUVR is probably going to be off too, and your centiloid is going to be off. So the other thing is making sure that your PET, your CT and your PET are in proper alignment. If they're not, your attenuation is going to be off, right? MR as an attenuation method doesn't work as well in every single patient as CT. So you've got to think about your PET-MR systems. How well are they coping? Is this person really working well with their MR as an attenuation method? Think about all of those kinds of things to make sure attenuation is correct. If your attenuation's off, your quantitation is going to be off. Simple as that. The other thing is positioning. Now, I know in all the protocols and all the settings, you have your EAM line straight. I'm saying no. I'm saying tilt your chin down. And the reason for that is because I want the cerebellum to be away from the edge of the scanner. Particularly if you've got a fairly narrow field of view scanner, you don't want that cerebellum affected by the noise and the artefacts near the edge of the scanner. So if you tilt your head down, your cerebellum is closer to your grey matter in terms of position in the middle of the scanner. Dead in the middle of the scanner, you want your grey matter and your cerebellum not right near the edge. And a lot of that can be solved by just having the chin tucked down. Now this is one of the most common causes of problems, and it's motion. So we've got a vacuum head holder. You get them for radiotherapy applications. And you can put them on the edge of your scanner. I turn mine upside down and put it on the scanner and tape it in. It works better because it holds the chin. This movement is the most common movement, the chin wag down, up and down. So if you put the strap around the chin, the head holder around the chin and around the forehead, then you're not going to get less of that wag. The other thing is to play music. Make the place pleasant and environmentally nice. And you also want sufficiently good straps so that when they fall asleep, which they do pretty frequently, they're not going to wake up with a start and move in. Give people a bit of coaching along that. And, you know, prevention is always better than a cure, but we are working, we're a test site for the Siemens motion correction. That does help a little bit. For example, here's a centiloid generated with and without motion correction, and it makes a significant difference. The other thing is making sure you verify all your details. Your SUV, your SUVR, and then consequently your centiloid depends on all the numbers in your settings being correct. So make sure that you've got the correct dose entered, the correct weight, the timing, the start, the stop, all of those kinds of things are correct in your system. Don't write in stuff that you think's appropriate. Write in what really happened. And the way we do it, we have it electronically done, so there's no typing by the most vulnerable part of the PET scanner. The most dangerous and vulnerable part of the PET scanner is me. Right? It's very easy to transpose two figures, 7997, right? If you've got all of those automatically entered, if you can work out a system to automatically enter all of those details, then you're less likely to make a mistake. All of those kinds of things really will affect how well it goes. The other thing that's useful, and we find essential, is to back up everything. We back up our raw data, which I know is a little hard on some systems. It requires a lot of storage. A PET scanner can, typical PET scan might take 5 or, on our newer ones, 5 or 15 gigs for a PET scan. But it means that we can then go back and reconstruct, improve the reconstruction, go back and compare it with other scans with similar reconstructions, because reconstruction impacts us as well. If you've made an error in typing and figure, you can go back and fix it. So it's important that you keep that backup in place. So the first step to producing a celluloid is an SUVR, right? And that's the ratio between your amyloid grey matter region and your reference region, which is usually your whole cerebellum. And it's got the advantage of minimising some of those errors that I just mentioned, errors due to weight, blood flow to that area and so on. One would expect that if you've got less blood flow to the reference region and less blood flow to your target region, they would balance each other out. So that's why we do a ratio between the reference region and the other regions. So it's an important thing that we do. So we get that done. But SUVR's not good enough. Why? Because each tracer has a different degree of binding. So your SUVR for different tracers is going to be different. Every tracer has a different degree of grey matter uptake. Each tracer has a different degree of white matter uptake. And every manufacturer has their own PET reference regions. So all of these SUVRs are going to be different, and each software program has got different reference regions, just to make things more confusing. So there are problems with SUVR. So you have the same subject, and you do a different tracer and you'll get a different SUVR. It's as simple as that, and that's really not very useful. So they came along with the centiloid scale. This is what Chris talked about before. 100 like the boiling water, 0 like freezing water. So you've got a gold standard tracer, which for centiloid was PIB, and then you compared its SUVR to the SUVR for the other tracers, and therefore you'd find a conversion between those two SUVRs up to, and call the group of people at 100 with AD and group of people at 0 with a healthy controls. But 0 is an average number. That doesn't mean you can't be below 0. 0 doesn't mean no amyloid. It means the average number for low amyloid, or very low amyloid. So in theory, this should fix the problem between traces, because you get conversion between the two. However, we're still working on improving centiloid. The partial volume effect changes centiloid. That means the spill out of radioactivity from your reference regions into the neighbouring region, or from the neighbouring region into your reference region of uptake, is going to affect the numbers you get. The reconstruction will change that spill in and spill out, because if you've got a higher resolution image, you're going to get less spill in and spill out. The scanner type is going to affect the resolution, and it's going to change your spill in and spill out as well. And you can do partial volume correction, but part of partial volume correction also has problems, because misregistration, particularly when you're doing MR for partial volume correction, means that it introduces a whole lot of new errors as well. And the registration between your reference regions and the actual scan, that can be a problem as well. In fact, that's one of the most common reasons why centiloid produces an erroneous value. The other problem, which we've discovered recently, is that is that the reference regions that different software programs use can be inconsistent. The whole idea of Centiloid was that we have a consistent way of managing it, but different software programs don't use those reference regions, they use their own reference regions. Solutions are being sought to fix this, and we are working with people to change that. One problem there I mentioned was the difference in resolution between different PET scanners and different reconstructions. We've published on how that impacts the Centiloid number, and we've got a method we can use with a phantom to measure the resolution for a different scanner reconstruction combination, and use that to match up with the gold standard scanner and adjust your Centiloid value based on that. It's not out yet, but it's something we're well working on. Katie will talk a little bit more about that later. So let's have a look at the difference in regions of interest. For example, here's Siemens Centiloid generated number, 73, and it's got a reference region and uptake, but these are not the official Centiloid reference regions. Here's a software program called Capable, and it uses the official regions, and it's giving a value of 93 Centiloids. So there's a difference of 20 Centiloids. Here's another program using a different set of reference regions, but they're closer to the official ones, and it's only got a difference of 2 Centiloids. We've found that if we're using the same software program and the same setup, when we repeat scans, we're getting very good numbers, very close to what we've done before. And if you do everything right, you can get within a few Centiloids of each other in a repeat scan. Here's MIMS. It uses yet another set of reference regions. And for that same scan, we've got 70.9. So again, it's a difference of 14 Centiloids. Again, they're using different reference regions. A different reconstruction will change your Centiloid number as well. We're up to 80 this time for that same scan with a different reconstruction. Low Centiloids have a different effect. Here's a Centiloid of 10.5 using a Siemens reconstruction, and here's Centiloid using the gain value at 16. So we've got a difference of 7 Centiloids there. Here's Flabitaben. Now, the Flabitaben regions are the official Flabitaben regions are a little closer to the official Centiloid regions, so the differences are not quite as bad. So we've got a Centiloid of 90 here, and we've got a Centiloid difference of 10. They're using different regions, but that's fine. And here's using Neurofit, which is one of the software programs, at a difference of 13. And in this case, it's this is using MIM software, and we've got 76. So we've only got a difference of 4. Now, this is a negative subject, and this is using flute-metamol. And one of the choices in the Siemens software is to use the PONS, which is a really small reference region. So we've got a Centiloid measure of minus 34. That's very low. But if we change that to the same reference region for Flabitaben, we get a measure of minus 11, which is closer to what we get when we use the official gain reference regions of 17. Again, here they're using a different reference region, but it's a larger one. We've got a difference of 8.9. And we've got a Centiloid value of minus 8 for this with MIMS. Now, if you look at the comparison between gain and that's the gain, that's the official Centiloid numbers, and the Siemens stuff, you can see that we're getting a difference of about 15. If you look at the Bland-Altman plots, we're getting a difference of about 15 Centiloids at 120 Centiloids, and that probably doesn't make much difference. But when we make a difference of 10 or 15 Centiloids at 10 or 20 Centiloids, that actually makes a difference to outcome, right? So just be careful about which regions of interest you're going to use. Here's here's the MIMS. Again, that's actually bigger than the Siemens difference. And again, it's the different. Sorry, this is the Singo one, but again, some of the differences here. I'll get you to the MIMS one. Quite big numbers here in terms of differences. They're like 25, there 25. It's a bit blurry. I did get this from just yesterday. They only got the data yesterday from MIMS, from their publication. But it's there's some quite big differences here between that and the official stuff from ADNeT. Now remember, a lot of these stuff from ADNeT, which is where we contribute a lot of our data, is old. And a lot of the stuff from GAIN that they've used for this is old. It's 10 years old. The centiloids were established. So we've also got new scanners these days that give better resolution, right? So if you're calibrating your machine and your regions of interest against old scans, then you're probably not getting optimal results for today's scanner technology. And we're working on improving that. Let's talk about how we generate a centiloid. I'm going to show you some screenshots from the Siemens system. The first step in their system, you simply load up a CT and a PET. You can do a PET alone if you like. But I think you tend to get a bit better results if you combine the PET and the CT. And you check that this diffusion between the CT and the PET is correct. And that's what we've got here. Looks pretty good to me. Most of the software programs are pretty good at registering these days. I know they talk about it as a common course of error, but they're not bad mostly. But you do need to check this. So you need to check whether they've got it exactly right. That reference region might be a fraction off, but it's not too bad. So you check the reference regions and then you measure the uptake. And it just gives you a screen with the uptake. Now, most of the software programs do something similar. Right? You just upload the scan and off it goes, puts the regions in and generates a centiloid, whether it's MIMS, whether it's NeuroFed and so on. I'm going to talk a little bit about each different software program. This one you can't use. Right? It uses the official regions and it was developed by the CSIRO in cooperation with Chris and AIBL, who we do an awful lot of scans for here, and it's been a long-term project and something. It generates an SUVR, it does a centiloid. It doesn't do a CT registration; it just uses the PET alone. It's not TGA approved; it's not FDA approved. It's free for us to use it in research on odd occasions, but it's not for clinical use, and it covers the broadest possible range of traces, which is excellent. And it gives you some other choices, some of those other reference regions that are a little more tolerable to scan type and so on. This is the Siemens system. I'm going to put a question mark next to centiloid because it doesn't use the official centiloid regions, but it does generate a conversion between their regions and centiloid. It does give you a CT reference CT registration as well as a PET registration, or PET alone. It is TGA approved or about to be, and it's FDA approved or about to be. It does do FDG. It's certainly not free. But it doesn't cover NAV. It only covers flubendaben, flibmetamol, or flubetapir. It does give you some choice of reference regions. I would urge you to use the reference regions that are closest to the official centiloid ones, and that is the reference region that they use, which is the whole cerebellum flubetaben, if it allows you to do it. It gives you some restrictions in terms of that. Here's Cortex ID, which doesn't give you a centiloid, so it only gives you an SUVR, so we really haven't got a comparison. It is TGA and FDA approved, but again, it only covers the main ones. G is pushing MIMS, so maybe they won't be using this much longer. Brass is the software from Hermes. They do use it in Sydney. It's used quite a bit in Europe. It doesn't generate celluloid, it only does SUVRs. A lot of this software was written 10 years ago or more, before celluloid came out, and haven't really got up to speed yet. Hopefully that will happen. It's not TGA approved in Australia, but it is FDA approved, and it does cover the main FDA approved traces. MIMS, their celluloid's just about approved in Australia. I've got a tick next to it. I think it's going to happen every day. It does. Their software's not available in Australia to generate celluloid. I got those figures on the weekend. That's how close it is in terms of that. This weekend, they've only just been able to produce those things. It doesn't use the official celluloid reference regions. It does cover a lot of different registration methods, but it doesn't cover the NAV, unfortunately. I don't know a lot about this program. I haven't had a chance to use it. It is used in the US, NeuroQ, but again, no celluloid. PMOD is the official program that was used for the celluloid. So it's research only, and you need to generate your own regions of interest, your own normal databases, and so on. So not really of a great use in the clinical context, but obviously it does a good job. It was used to generate the original celluloid. ScalePET is not available in Australia. It is FDA approved, or about to be. It's a Korean program. There's several Korean programs. The Koreans seem to be really moving ahead with this program. They use some sort of artificial intelligence to do their registration, which seems to be really good from what I could see. However, they don't use the official celluloid regions. And in order to generate a celluloid in the current set of software, you require an MR, which again, most instances these days, MR is not always being used in combination with the PET scan. But it does cover all of the traces, and I think NAV is almost there. So it seems to have a lot of features, but it's still missing some features. NeuroQ, it's similar to Centimed. It's been bought and used at the moment on United scanners. Doesn't produce a celluloid, just does SUVR. So the others of worthy mention are Neurostat, but that's FDG only. IQ Load, which is what is used by the big commercial research company, doesn't produce a celluloid. It produces a competitor to the celluloid, if you like. So really that's not available in terms of that. And Huron, I haven't managed to get a lot of details on, but it's also another Korean product that seems to be coming out. So quantification is essential. In our experience, unless you're Chris Rowe, it's very difficult to give an accurate celluloid number without some software. Technical factors really impact your celluloid number. That's particularly timing, QA, registration, regions of interest, and the software. Now, we're working on being a bit like the United Nations and working with others so that we get similar values from different software, similar values from different PET scanners, and similar values from different traces. And that's part of the research we're doing here, so Katie will talk a little bit more about that. But it's an important part of the work, and I think it's a shame that as a clinical site, all of your clinical sites, when you do a celluloid, you're going to get, no matter what trace or scan you get, you want to be able to produce the same number as someone else so that when the therapies come along, you can be confident in the number you're giving. Hopefully down the track, we'll be able to do that. And thank you to everybody. There's been an awful lot of people at the Florey, at the Austin, at the University of Melbourne, and CSIRO and the National Imaging Facility, which we're part of, that have enabled this to happen. Thanks.
Yes, Chris has had to admit that I actually thought my first talk was 2 hours long, not 1 hour long. But anyway, it's all good. So, just a quick refresher on NAV. Negative NAV amyloid scan, as you can see here. Lots of space between the hemispheres, no filling in of the cortex. That's a bad one. Okay. Another negative NAV scan. That's what it says, doesn't it? Yeah. This was... Yeah, I'm covering up something I wrote. It's all right. So this was just to remind me to mention, which I already have, that in young people, they have more plump brains, plump white matter. If you don't... I have unfortunately seen one of my colleagues call a negative scan positive in a young person, and the result was fed back to that person, and that person then threatened to commit suicide. Turns out it was the 5th time they'd threatened to commit suicide, so it didn't come as a big surprise. But it was a bit of an embarrassment when they had to be called back by their specialist and told they didn't have amyloid in their brain and they weren't going to develop Alzheimer's disease. So there is a downside to overcalling these scans. This one is also negative. There's still a good degree of space. There's no filling out of the cortex. It's all lots of fingers. This one is negative too, and it's just to show that in some patients you occasionally get very bright white matter uptake in the hemispheres. The colour setting in the cerebellar white matter looks about appropriate. But in this particular person, obviously the hemispheric white matter is very bright as well, but it's a negative scan. There's nothing going on out in the cortex anywhere. And here's a typical positive. You clearly see the cortex lighting up in red all over the place. Another clear positive, not as much as the previous one, but you've lost the fissure. Everything's merging together here in the middle of the brain with a precuneus and posterior cingulates have now filled in with amyloid, so you're losing that gap between the hemispheres that's accentuated when there's no uptake in the grey matter. And there's uptake clearly in cortical regions as well, and a little tiny bit in the striatum, so this is a moderately positive scan. In particular, the temporal lobe's positive in this person. And an exceedingly positive scan, as you'll not infrequently see, and it's not overexposed because the cerebellar white matter doesn't show any red. In fact, if anything, it's underexposed. Occasionally the technologists have to turn it down once they've said it correctly because it's just all red. So some are brilliantly positive. Here's a bit of a case. This is an FDG PET. It's a 64-year-old woman referred with a mini mental state score of 22 and not much else. And I'm going to ask you to look at the FDG PET, remembering our first part of my talk long ago. So have a look at this. Decide in your brain, in your mind, what you think the diagnosis is. I'll show you the neurostat in a minute. Here's the neurostat. I'll show you the questions. Are you ready to go? Or okay.
Use the QR code from before, which I should have. So you can join by going, hang on a minute, see, is it that? It's not going to be able to. Okay, if the QR code is too small, sorry. If the QR code is too small, you can join by going to polev.com and just /amyloid. Just going to put it on the screen.
Ignore this scan because it's not related to this case. Okay.
Sorry, this is your.
I'll take you back to the FDGs.
This is your case here. So just go wherever you want to go.
This is, sorry, different program. Nope. They're not on here.
Oh, okay. Well, that's good. Okay, can we go back to him then, please?
Yeah, we'll just do these few off of mine, and then we'll swap over to the second file. Okay, so going back so you can have another look. Oop. FDG PET, Neurostat. What's your diagnosis? Well, we can't tell, can we? Who thinks it's normal? No, good. Who thinks it's Alzheimer's disease? Not a lot of conviction. Who thinks it's late, limbic predominant age-related, TBV, 43, encephalopathy? No. Who thinks it's dementia with Lewy bodies? Who thinks it's vascular dementia? Who thinks it's frontotemporal dementia? Who thinks it's mixed dementia, Alzheimer's disease with something else? Okay, so we had quite a few hands that were sort of hesitantly going up for Alzheimer's disease and quite a few that were going up hesitantly for AD, and I can see why there was that hesitancy here, because the neurostat is showing predominantly frontal, but there is posterior cingulate back here as well. There is a little bit of parieto-temporal, so there are some AD features. And if I go the right way, no, that way. There is some reduction. The posterior cingulate precuneus is certainly not the brightest thing on the slice. Sensory motor cortex is, it's preserved. The frontal is down. There's a bit of parietal down. But, yeah, I can understand why there's a bit of uncertainty. So, in this case, in my report, I might have written, which I sometimes do, an amyloid scan can be done with the department, but the patient will have to pay $1,000 out of pocket. And here's their amyloid PET scan. And what's the answer to that? No amyloid? Anyone think there was no amyloid? Mild amyloid of questionable significance. Moderate amyloid likely to cause symptoms. No one? High amyloid, definitely sufficient to cause symptoms. Yeah. Or uninterpretable? No, obviously not. So this was an extremely clear case where the amyloid scan was cut and dry. The FDG PET was strongly suspicious for Alzheimer's disease, but had surprisingly amount of frontal involvement. Centiloid estimate. Anyone want to guess at what the centiloids would be on this? Would it be less than 20? Would it be 21 to 40? Would it be 41 to 70? No. Would it be 71 to 120? Yeah. Or greater than 120? Yeah, it's one of the last two. It's a bit hard to do that. Hang on. So it's clearly quite bright red. It hasn't been, the colour scale's about right. You've got red appearing in the cerebellar white matter. And it's probably about 110, 120 or something like that. So we've been through that. And so the PET diagnosis is now Alzheimer's. Here's another case. 72-year-old retired journalist, 2 years of memory decline, poor concentration and inappropriate comments. However, he's got a history of multiple closed head injuries over 30 years, hit by a car, hit on the head with a hammer, and has also fallen off of a roof. Testing showed a mini mental state score of 21 out of 30, so that's definitely impaired. Amnestic, so on delayed word recall, scoring minus 2.5 standard deviations below expected for his age. Boston naming test, which is just looking at pictures and saying what they are, was surprisingly bad. But the neuropsych report was consistent with Alzheimer's disease. But the clinician noticed silly childlike demeanour and inappropriate jokes while they were being tested. So the MRI was done, and the MRI reported gliosis and atrophy in the anterior temporal lobes, right worse than left, and also severe hippocampal atrophy. And there are enlarged sulci, meaning there's some atrophy in the medial and orbital frontal lobes. So this is a bit of a complex case of brain trauma, now in the remote brain trauma, now presenting with cognitive decline. And this is the FDG PET. I want you to have a look at that and see if this helps you make a diagnosis of a particular type of dementia. I'll show you the neurostat in a minute. Here's the neurostat. What's it going to be? Normal brain metabolism. I saw your hand go up. I think he was scratching his nose though. Alzheimer's disease? No. Late? 72 or something? Dementia with Lewy bodies? Vascular dementia, frontotemporal dementia, mixed dementia. Okay. Well, on the report I said features of a lot of the findings are explained by the traumatic brain injury. He had bilateral temporal lobe gliosis, he had some frontal lobe atrophy. If we go back, if I can click the right way, there are a few AD features in here though. There's the parietal cortex here, and there's a bit of posterior cingulate precuneus, but certainly the main abnormality is this temporal lobe and frontal lobe damage. So a bit hard to know really. I would agree that this is inconclusive. So we had an amyloid PET scan. This time you had a fluor beta ben PET scan. So this time, to make it hard for you, it's fluor beta ben. So have a look at this and decide whether you think it's positive or negative, and how much positive, if it's positive. Okay, who thinks there's no amyloid? Mild amyloid of questionable significance. Moderate amyloid likely to cause symptoms. Okay, got quite a few hands. High amyloid definitely sufficient to cause symptoms. Probably the majority. Poor quality due to head motion or other artefact. Yep. Yeah, it's positive. And for a fluor beta ben scan, this is a high positive, because in the frontal lobes you can actually see activity in the cortex that's greater than white matter. You have completely lost the white matter appearance. You've got tracer going out to the parietal cortex, and part of the precuneus here you've got activity greater than white matter, and it's everywhere. So this is about as positive as a fluor beta ben or a fluor beta per scan gets. So what we've got here is a person with long-standing severe traumatic brain injury who's now developing Alzheimer's disease. And the picture's a bit mixed up because you've got an interaction of deficits from the traumatic brain injury plus the Alzheimer's disease. But the reason they present now declining is Alzheimer's disease. I better go through how to read these fluor beta ben, fluor beta per scans a bit more. So what we have here is a fluor beta per. It's in an inverted grayscale. We've adjusted it to our preference, so I sort of like it to look like this, which is very scientific, but not too light, not too dark. Review the white matter tracts for grey-white differentiation. Look for kissing of the hemispheres and smoothing of the cortex. So if we look through this, it all looks pretty clean up around here. There's a nice gap, but then some of these areas might be getting out to the cortex. Might be smoothing in a little here, but it's pretty subtle. Then in the frontal lobes, this is looking a bit smooth, so that's a little bit concerning. But not a lot. So if anything, it's only mildly positive. So I would play this one down as being insufficient to cause cognitive symptoms. There is a suggestion of a mild degree of amyloid present, but not to get too excited about it. This is a clearly negative one. I probably should have showed you this first. Transaxial slices, and you can see beautiful pictures of white matter, nothing out in the cortex anywhere. In the midline sagittal slice, nicely seen corpus callosum, no activity around it, it's just all sitting there by itself. And if you look at the ratio of cerebellar grey matter to cortical grey matter, you see it's pretty similar. So this is a beautifully negative Fluor-Beta-Per scan, which you can be 100% confident about. Fluor-Beta-Ben, you read it the other way round supposedly, but as I said, it doesn't really make any difference. I read them all black on a white background. But here's a clearly positive Fluor-Beta-Per. The grey matter pattern is lost. It's filled in out towards the cortex. The gap has sort of largely disappeared between the brain hemispheres. Temporal lobes are all filled in. In the mid-sagittal slice, it's hard to see the corpus callosum because there's activity in grey matter in this sort of, it's not quite a triangle, but posterior cingulate precuneus area. And when you look down here on the coronal slice, cerebellar grey matter is completely different to hemispheric grey matter. So remember, no plaques in your cerebellar cortex in Alzheimer's disease. So this is what cortex should look like if there's no plaques, but in this case it's clearly filled in with amyloid. So again, a strongly positive, this is a strongly positive Fluor-Beta-Ben scan. A bit of recommended reading, you might want to take a photo of the slide. Are we making these slides available? Yeah, okay, don't need to take photos. Just pay my commission. So this is some articles we've published over the years on how to read scans. This is the official reader training that you should really do as well as what I've been teaching you. This is the flutamidamol one. You go to this website, you select the country you're in, then you enrol and you do the study. At the end of the study, you get a certificate saying you've completed the training scheme. This is the Fluor-Beta-Ben, also called neuroscience, similar sort of thing. Go to this website, register, hit play, go through the 5 modules, do the test at the end, and as long as you get more than 80% correct, you get a certificate that you can then download and keep as a record that you've done the training. And the same for Amyvid or Fluor-Beta-Per. Go to their site. Say you're a health professional. Now, I did the hotel I was staying at a conference in the United States, and that got me access to this training program. Then you can go through it and get your certificate that you've completed the training. I have got some YouTube videos. You can access them through the Australian Dementia Network. They're pretty similar to what I've been saying today, how to read brain PET cases. There's also how to read FDG PET if you want to hear me droning on some more. And that's it. Now we change over to the other file.
So I'm not sure what question you want first, but I'll show you the list of questions. So these are your 4 questions.
Okay, and now this will show cases.
So down.
Okay. All right, here we go. Here's a Fluor-Beta-Per scan. Read it, and then questions are the amyloid PET scan shows.
Have you guys been able to do the QR thing? Yeah. Yeah? Good. So otherwise we can...
Actually, that didn't cut. Oh, right. Okay. Okay. This is what...
So, yeah, as they start to select.
Okay, jump in before everybody else does.
You need to activate.
Oh, it's not activated. It did before. Oh, it unactivated itself. Thank you. Deactivated.
Okay.
It's time.
So no amyloid, mild amyloid of questionable significance, moderate amyloid likely to cause symptoms, high amyloid definitely sufficient to cause symptoms or artifact.
You want us to note down those responses or you
We should have a timer on, shouldn't we?
Yeah.
Okay.
very
Time's up. Okay, 50-50 between moderate and high. I would go high because this is as good as it gets for a flabeta per scan. And if you look at the occipital lobes, particularly the occipital poles, I don't know if this will work. Do you see an arrow?
have you got
Yes, you do. It's all right. There's an arrow. It's actually greater in the cortex than it is in white matter. So it's exceeding white matter activity. But you've largely lost corpus callosum. It's not nice and bright. You've got posterior cingulate. If you look down here, cerebellar grey matter versus hemispheric grey matter, there's clear difference. So moderate's fine for your report. It's a positive scan, no doubt about it. And whether it's moderate or high is a little bit academic for clinical purposes, but I'm being mean to you and making you choose. And I think next one might be
just go through?
down figure.
Yeah.
Or not.
Mm.
Right, I've done that.
Yeah.
Don't know whether we really want to estimate centiloids on the black and white ones. They're a bit hard. Here's the next case. So if you could reset that.
Yeah.
Again, another flabeta per scan.
No, they've just done it to be really fast.
Can you vote? Is it working?
Yeah. It's quite interesting watching all that's coming in.
This won't do anything if I look at my cases on here, will it? No. I'm going to make it a little easier for you now, before you finish. Well, I should have showed it before. No, that's something. Okay, so mild is, it's good, I agree. This is not a very obvious one. And so when it's a bit questionable, it's important to look in those other planes. Yeah. So here's that scan now, and now we've got the sagittal and the coronal planes thrown in. Can we re-vote?
Yeah.
Can we go from 86% mild?
Yeah. You want me to clear them? Or people have a second vote. Here, I'll clear them.
Clear them. So we've got a few people now going into the moderate category. And I agree, this is mild to moderate. Sometimes I say that. So now we can see there is activity back here in the posterior cingulate precuneus area. And again, if we look at cerebellar grey matter versus cortical grey matter, it's not greater than white matter, but it's certainly increased to some degree. So this is why we need centiloid numbers, because there are these cases, And in cases like this, I have actually noticed that sometimes I'm discrepant from central readers reading for clinical trials. I tend to be a little bit more sensitive, but when we do a NAB scan, I'm right and they're wrong. This person would probably light up quite nicely on a NAB scan. I suspect they really do have, well, at least 40 centiloids of amyloid.
Is 40 enough to cause symptoms?
Oh, it's on the borderline, isn't it? And just some arrows pointing to the areas that I felt made this case mild to moderately positive. That frontal lobe up there on the top right-hand side is smoothed out, suggesting there's cortex uptake. There's a little bit of parietal there in that second from left in the top row. As I pointed out before, on that mid-sagittal slice there's a bit of uptake, and then on the coronal slice there's uptake in cortex. Next case.
Do you want me to change the questions, or you have your question?
Same question, yep. Okay, 87% high, 12% moderate. Yes, correct. Clearly the cortex is looking smooth just about everywhere, meaning there's activity and binding out in the cortex. The corpus callosum's disappeared almost. There's lots of stuff in the midline, and that cerebellar grey matter is a lot less than the hemispheric grey matter. So that's clearly a positive scan, enough to cause Alzheimer's disease. Next one.
Do you prefer to read black and white or colour?
I much prefer colour.
Even if if it's the same scope.
Sorry, it depends on the tracer. You can't read these in colour because a lot of that sort of more subtle stuff that we're calling just looks so much less than the white matter when you go into colour, because colour is more contrasty, so you lose some of that smooth change and it exaggerates changes. That's great if you've got a highly avid tracer. Just brings up the cortex and the white matter disappears, but when you've got one that's not great, it tends to do it the other way around and bring up the white matter and make the cortex disappear. So, okay, you've already voted, very good. Okay. So we do have a third of people thinking this might be mildly positive. Anyone want to volunteer why they think it might be mildly positive? Anyone feeling brave? Sorry?
Just that the right area is really
Yep.
most obvious.
This sort of area is a bit concerning. Yeah.
Especially if you compare it to the left.
And the rest.
So, I mean, like, if you
Well,
look at the axial, you can see compared to the left, the right's just a bit bumper. Go to the next slice as well.
That
the
one.
other way. The other way. See how it's a bit
Yeah.
bumper there compared to the left.
Yeah.
And then also on the coronal, you see it as you go through the middle slice there, you can see it.
Yeah. I agree. And there's just a haze here as well. You can still see the corpus. So this is mild at most. Now, I think most people would call this negative, and as I said, I'm a bit of a high sensitivity reader. This, I don't think, is enough. It's not sufficient to cause symptoms of Alzheimer's disease. So if you're playing it safe, you'd call it negative. If you think your clinician's sophisticated enough that they can handle a mild result, unlikely, what's the terminology we use? Of question, well, it's insufficient to account for clinical or cognitive impairment is what I'd probably say. Mildly positive, but insufficient to account for cognitive impairment. You might want to report it that way. Depends a bit on how sophisticated your audience is, and but basically you could just call it negative to keep it plain and simple. But I agree, I think there's a touch of amyloid in this person. This is the same one, I think, yeah. Okay, here's an FDG PET scan. Little pictures, 73-year-old mini-mental state score of 25. I need FDG PET for this one. And there's no neurostat.
Sorry, hang on. Can you see the right physical? Yeah.
People are reluctant to vote on this one. I can see the voting's going slowly because it's jumping all over the place. So only a few people have voted. But we seem to have stabilised on Alzheimer's disease. And I think that is a reasonable call because there is a reduction in the posterior cingulate precuneus. It's not the brightest thing on the slice. There's a little bit of reduction in lateral temporal regions, a little bit of reduction in both the medial and lateral temporal lobes, but it's not glaringly abnormal. The parietal cortex doesn't look too bad, so it could be mild cognitive impairment phase of Alzheimer's disease, because as I mentioned, the degree of abnormality is proportional to the degree of cognitive impairment. But there is grounds for uncertainty. Here's their amyloid scan. Yeah, amyloid. Thanks. This is a NAV scan, hence it's in colour.
Amyloid PET scan, sure.
Yeah. Okay. Here we go. Okay, the audience is getting quite sophisticated now. I would also call this moderate, but definitely sufficient to cause cognitive impairment. It's predominantly in the frontal lobes, but there is also some back here in the precuneus posterior cingulate region, and you have got quite marked uptake in the caudate nuclei, the anterior striatum. But it's predominantly a frontal lobe positive scan. We've done that. Who wants to guess the centroids on this? Because we do have the answer. We'll just put that up. I'll put the image back up. Yep. $40 to $70, I think that's excellent. Let's see what it was. 82. Ah, well. Anyway, definitely positive, definitely enough to account for cognitive impairment, which is the main thing. A tiny FDG PET scan. I don't know if you can see it or not. FDG PET again. This time you do get neurostat, so hold off. Sorry. I'll show you the neurostat. Yeah, not a straightforward scan like many FDG PETs are. In reality, I report 12 FDG PET scans every Wednesday, and I think half of them are straightforward, and the other half you've got to scratch your head about a bit. They're not all easy. So on this one, we are seeing some changes in AD regions. We're certainly seeing posterior cingulate precuneus. Perhaps down here it's a bit more clearly seen. We're seeing a bit of parietal, and on the superior views we're seeing a little bit of parietal. But we're seeing some lateral temporal, but it's all quite patchy, and I'd be going for AD, but it's not quite your straightforward scan, so saying possibly mixed, possibly AD. Actually, if we go back, some people did select late. And that's not an unreasonable thing to think about, because the medial temporal regions are fairly down. Neurostat's not very good for medial temporal, unfortunately. It's got to be very severe before neurostat will pick it up. So on the inferior view, you have a look. It's not picking anything up on the left. They might be picking a bit of something up here on the right. And there's the FDG, the amyloid brain PET scan on this person. Do we even need to vote? No. Clearly Alzheimer's disease.
Over 120.
Yeah, pretty close. 120, 121. Back to floor beta per. This looks awfully like something we've already seen, but it's not. It's actually another case. Yeah.
Which one did you do?
The amyloid PET scan shows. The reason I'm showing you a lot of floor beta per and floor beta ben is, unfortunately, that's probably all most of you have got access to. You can buy the doses from Cyclotech. NAV is a bit, unfortunately, because it's not FDA approved, is a bit more tightly controlled at the moment, and you may not be able to get access to that. So you might have to be reading these black and white images, I'm afraid. So this one, we've gone for moderate amyloid, likely to cause. A few people have said mild. And yeah, this is pretty similar to one we've seen before. There's a bit of activity going out to cortex, frontal regions, frontal lobe here. In the midline, there's a little bit of activity running along the corpus callosum here, but definitely out here into the precuneus, and looking on the coronal cerebellar grey matter. It's considerably less than hemispheric grey matter. So this one is a bit of a borderline one between mild and moderate. I would say I might sit on the fence and say mild to moderate amount of amyloid present. Unfortunately, it leaves you giving a bit of a grey answer, and I just leave it up to the clinician to decide on the significance of it. Another floor beta per scan. If you want to reset, please.
So when it's mild to moderate, what's the centiloid then?
Mild to moderate's probably around the 40 to 50 mark. Anyone would have a guess at this? Yeah. Okay. The good news is that it's actually, I had to search quite hard to find these difficult cases. Most people either seem to be strongly positive or clearly negative. In fact, it makes research a little difficult when you're trying to do research around the threshold levels because there's not many people there. I don't know why, but it's fortunate. So most people with cognitive impairment, if it's due to Alzheimer's disease, will have a clearly positive scan. And if it's not due to Alzheimer's disease, they'll have a clearly negative scan. So I'm making it a little bit harder than usual by showing you these equivocal cases. This one, mild. I agree, this one sort of looks a bit blurry. I'm a little bit concerned about movement artifact in this person. And it's not, I'd probably blow this one off as negative. There's nothing much going on around the corpus callosum. You really haven't smoothed the cortex out all that much, although you'd be a little concerned about this sort of stuff. And on the coronals, well, it's a bit patchy, but it's not, hasn't filled in smoothly up around here at all. So I think I'd just call this one negative, be done with it. Okay, next. Good. I was a little concerned there when everyone was saying mild, but now we've got the answer right. It's moderately positive. This one's fairly clearly positive. You've got activity going right out to the cortex here in the parietal regions. The gap is sort of getting a bit thin, filled in a bit. On the mid-sagittal, you've got activity here, precuneus, posterior cingulate, sort of blurring out the back part of the corpus callosum. There may be some orbitofrontal in here, and if you've got cerebellar grey matter, well, relative to hemispheric grey matter, there's a clear difference, particularly you go back here and compare that part of the cerebellum to the cortical grey matter, the hemispheric grey matter. So yes, this is at least a moderately positive one, and I'll be pretty confident about calling this moderately positive. Oh, back to my favourite. Now, if this is a true case, this person came straight for an amyloid scan. 67-year-old lady with a strong family history of Alzheimer's disease, an ongoing memory decline with a MOCA, that's a Montreal Cognitive Assessment score of 20 out of 30, scoring with a short-term memory, remembering 5 components, she only remembered 1 of them, and she presented for diagnostic evaluation. So the MOCA is scored out of 30 like the mini-mental state, but it's a bit harder. It's more sensitive for picking up mild cognitive impairment. So if you scored 27 on an MMSE, you'd expect to score about 23 on a MOCA. So scoring 20 is impaired. It's not horrible, but only getting 1 out of 5 object or name recall is very, very concerning. So the person has amnestic MCI at least, if they're still functioning well. If they've got functional impairment, then they've got early amnestic dementia. So here's the amyloid PET scan. Can we have that, thanks? The report on that.
So you want to get some question?
Amyloid PET shows, yeah. Okay, so no amyloid is the correct answer. Again, this is a younger person, so they tend to have a bit of a more expansive looking white matter parts of the brain. Interesting, there's a little, a little dot of intense activity. See that there? Who wants to guess as to what that might be?
Angioma.
Yep. So this is a clearly negative scan, and they've got an incidental small meningioma. That's not big enough to do anything. It just needs observation.
What's causing the reflux?
Well, here's their FDG PET scan. And we have Neurostat for this, so I'll show both. Have a look at this first, and then I'll show you the Neurostat. Don't vote yet. Can you put up the amyloid, the FDG result? Now I'll show you the Neurostat. And we can go back and look at the FDG slices in a minute, and then you can vote. How many of you missed the temporal lobe findings on the FDG PET when looking at the slices? Well, you don't have to admit it, but don't forget to look at the bottom row. And this is something I've had to drive home to our registrars, etc. They're too busy looking up the typical AD areas, and they forget to look at those last few images where you're seeing what's going on in the anterior temporal lobe. Okay, and people have voted, but it's not what I'd vote for. Because remember, this person's only 67. Sorry. Remembering the history, 67, strong family history of Alzheimer's disease, decline on motor and cognition, seemed amnestic. What we're actually seeing is semantic dementia. So this is affecting the anterior temporal lobes, left worse than right. We know the person's amyloid negative, so it's not some sort of strange presentation of Alzheimer's disease. And although these people usually present with a fluent language problem, I mentioned that they can hold a superficial conversation. How are you today? Fine, thank you, blah, blah, blah. But what is an elephant? Elephant? They don't always present exactly the same. So this is a bit unusual that patients presented with an amnestic presentation rather than a language presentation. But the FDG PET clearly shows severe bilateral but left worse than right anterior temporal hypometabolism. And so our best bet is that it's semantic dementia, which is a TDP-43 condition, just like late. So there is a bit of, I guess if this person was 85, they might be calling this late. But they're only 67, so it comes under the rubric of semantic dementia. This was the low-dose CT done for attenuation correction, and actually it gives you the answer. These people also have severe anterior and medial temporal lobe atrophy, And you can see here in the left temporal lobe, there's severe atrophy in the anterior pole of this left temporal lobe. So that alone should, when you see it, should tip you towards semantic dementia. And I think that's it. I think we're done. My goodness, thank you.
Thanks, Chris. So if you don't mind, I'm just going to put up the 2 questions that gauge people's comfort with amyloid and centroid scores, just to try and determine how well we've done, I guess, at upskilling you. And then we're going to run the panel, and I'll do my talk after that, just to give you guys a bit of a chance for some interaction rather than sitting. Pardon? Yeah, I just said I'll do the questions. Unless there's other questions I'm not sure about. They're the ones, the Rob's. Hang on. Am I still there? Yeah. So these ones this one, right? You can't activate it on that. So I'll just, Rob, that's this. That's what you mean, right? So if you don't mind answering that one and the second one, and then we'll run the... A bit disappointing if you said no on that one. And this one, maybe we shouldn't look, Rob. It's almost like a lecturer feedback. I'm not sure what the name I'll ask him. Okay, so do you want to but because I'm going to now, then there's a time at the end of my talk, which is about reconstruction. Okay, so really okay, so I'm going to take it away from the clinical. Can you hear me well? So, can you guys hear me okay? Is it okay? So I'm obviously not a clinical person, I'm an engineer, so we're going to pull it back into the engineering side of things, which is, I think it's about time. Apologies if this is going to be fairly rudimentary for those who are well across this reconstruction. So obviously the PET images are reconstructed from a list of radioactive events. So for the reconstruction you just get a very long list of radioactive events that are captured by crystals. So for those who are not familiar with this, we have when the patient is injected with a radioactive tracer, there is a positron. When there's radioactive decay, a positron is emitted and collides with an electron, and this annihilation event then causes 2 gamma particles to fly at opposite directions, and then they're captured by the crystals in the scanner. So when we get this list of it's the university being bossy about IT. When we get this list of radioactive events, then we need to turn them into an image, and the way we do that depends on the algorithm, and it's important for us to acknowledge that different algorithms have different quirks, and that can really change. So with the PhD students we've had have really shown how the algorithm greatly impacts the centiloid values that are reported, and even around those threshold values. So all this talk of false positives and negatives, you know, if the algorithm you're using can really cause misreporting. So this, for example, is the same data being reconstructed by two different algorithms, and you can see there's obviously quite a large difference. So each algorithm as well, not only the choice of algorithm, but then each algorithm has parameters, and then the parameters that you choose also impact the image, and that's most notably with the spatial resolution. So each row here are 3 slices of the subject's data. So it's the same data acquired on the same scanner, reconstructed with the same algorithm, but here all we've changed is some of the reconstruction parameters. So in the top row, they're all with the same reconstruction parameters, and so the middle row and the bottom row. So the idea here was to compare, was to try to visually match. So the top row and the bottom row, we've tried to visually match them and make them as similar as possible. And in the middle row, we've tried to statistically match them. So if you compare the slices in the top and middle row, if you take a sum of the differences squared, then they are more alike than the top and the bottom row, even though you wouldn't know that visually. And that's because of the particular type of noise that's present in PET data. So the algorithm, the biggest impact it has is spatial resolution, which is our ability to distinguish between two separate objects that are close to each other. So spatial resolution determines how well the PET scanner resolves the fine details of the structures or tissue being imaged. And why do we care about this? Well, obviously the ability to resolve detail is impacted, but also because it induces what's known as the partial volume effect, which is a big issue in PET. So if we imagine that that centre dot is a real object, because of the scanner, you've only got so many crystals being able to detect. Also, the positron travels a little bit before it is annihilated with the electron. Well, these things induce maximum precision in that we can identify the actual object. So that causes a sort of blurring, if you like, of that object over space. And then we're representing the object discretely on a computer. So we put a grid across that object, and there's actually 3-dimensional voxels. And then we finally, each of those grids or positions or voxels gets a single intensity value. So the problem here is that some of these voxels contain the object of interest plus the background, but we only get one intensity value. So that means it's that volume has partial image and partial background, which is why it's known as the partial volume effect. And the partial volume effect impacts our image differently, or particularly impacts centilloid differently, depending on if you've got a high centilloid or a low centilloid. So the way the partial volume effect changes our centilloid estimate is not the same all the way across that centilloid scale. So obviously, the higher the spatial resolution, the better, because we get less partial volume effect. If you've got higher spatial resolution, you've got more voxels inside the object compared to those sitting on the boundary. So we get to choose our reconstruction parameters. So, well, the scanner, firstly, it has hardware which impacts our spatial resolution. It's got the crystal layout and the size of the crystals and things. We can't change that. What we can change is the reconstruction algorithm and its parameters. So the parameter choice, as I've said, impacts the spatial resolution, and I'm going to go through an outline of the algorithm, the main dominant algorithm and the parameters. So this is a screenshot of the Siemens console, and so down here is where you set the parameters for reconstructing the image. This is an example. We're doing a motion correction validation for Siemens, so this is an example of someone who's deliberately moved in the scanner. So the first thing we need to do is select the algorithm that we're going to use, or reconstruction method. In this case, we're selecting the iterative method, iterative plus TOF, which is time of flight, that I'll explain. So the iterative algorithm is exactly that, it's iterative. So we input the crystal activity acquired during the patient session. We want to output an image, but the iterative methods reconstruct the image iteratively, so multiple times, and every iteration improves the statistical quality. So first of all, we calculate the crystal activity that we would expect to get from our current image estimate, and then we calculate the difference between the measured and expected crystal activity, and based on the difference between those two, we update our expected image, and then we keep doing that. We keep iterating until there's not much change between iterations. So that's the basic, very, very broad outline of the algorithm. So given that we're going to do multiple iterations, the first parameter we need to select is the number of iterations. So how do we know how many iterations to use? We can, if we do a full iteration, that means we're going to iterate until there's no change between iterations. It's like a tongue twister. So the problem with this is that it can sometimes look noisier because we are trying to reconstruct something that is inherently noisy. Radioactive decay has a probabilistic aspect to it, so it is inherently noisy. So we're actually trying to, if you like, reconstruct that noise if we're going to be faithful to reconstructing what's actually happened. So it can look noisier. If we do a partial iteration, it means we exit that iterative process after a set number of iterations. So we might just do 10 iterations, and there may, when we're going through the iterative process, there might still be a significant change between the iterations, but we're deciding to exit that earlier. And the reason people do that is so that the image looks smoother, because we're not going to iterate until we have the difference, the highest spatial resolution that we can possibly get because of the inherent noise in the image. So it can look smoother, it's less statistically accurate, and there's less definition between structures because it is smoother. So the next parameter we get is subsets. So traditionally, the iterative algorithms are very slow because you're not just reconstructing once, you're doing multiple reconstructions. And if we iterate over the full image, all the voxels, there's tens of thousands of them, and it can be very time consuming. So dividing the image into subsets speeds up the reconstruction. So in one iteration, we may just update, I should say, that yellow, some subset of angles in each reconstruction. We might then, in the next iteration, we'll do the green and the red and the blue and so forth. And by doing that, we're speeding it up because each iteration we're only updating a portion of the image. So why not just do even more subsets then? Because each subset has less data in it, so it's faster. But the problem is, with each subset, because we're only updating a portion of the image, we don't have as much information in each update, so it's a little bit noisier, and it can lead to artifact if we do too many subsets. Also, because you're only updating a portion of the image, it can be slow to converge, and like I said, it can be noisy if there's insufficient data per update. So therefore, there's a trade-off between speeding it up and having enough information per iteration to be able to do a good update. So what's the optimal number of subsets to balance this trade-off between a speed increase and the reliability of each update? The optimal, there's no set number because it depends partially a little bit on the project that you're doing. We typically use between 5 and 10 subsets. Often we consider subsets and iterations together, so you would take the number of subsets and multiply it by your iterations. So 10 iterations and 5 subsets, and 10 by 5, you'd consider that 50. And then because the number of iterations and the subsets both impact the spatial resolution. The next parameter we're looking at is time of flight. So the gamma rays travel in the opposite directions, and the two, because they make a line between them, we don't know exactly where that annihilation event occurred, and we call that the line of response. So when the crystals detect those gamma rays, we can see that the annihilation event occurred somewhere along that line of response, but we're not sure where. So the time of flight actually measures the difference in arrival time at the two crystals, and if it arrives to one crystal earlier than the other, then we know it was closer to that crystal than the other crystal. So that means that this line of response, before we just had to sort of accept that it could have been anywhere across that line, and now using the time of flight we could say, okay, if it arrived if it arrived to this crystal earlier than this crystal, we can assume it was closer to that crystal, which means now we can reduce the line of response, that the positions that are potentially where the annihilation event occurred. So that time of flight can be used to improve the spatial resolution, well, I should say the signal to noise ratio of the images. So that's a recap of the main parameters in the algorithm. I can't give you a set of optimal values for your reconstruction because it really depends on your particular study. So, I mean, sadly, the subsets are scanner and study dependent. The iterations are scanner and study dependent. We generally have the time of flight on because it can improve your signal quality. But ultimately, we recommend having two reconstructions. So one reconstruction for visual reporting is earlier on I showed you a scan, three scans, two that were visually similar and two that were statistically similar, and you could see that they were actually very different. And so the visual reporting scan, we tend to exit the iterative process earlier, so it's a bit smoother. You don't get quite so much of that black and white noise. So it's easier to read, but it's not as statistically accurate. So then we would do another reconstruction that is better for statistical quantification. So yeah, that's pretty much it for me. It's just a recap of the parameters. Are there any questions? That either means I did an excellent job or a terrible job. Okay. So that really wraps up the... Oh, yes, please.
Do you have any ability to change the inherent reconstruction algorithms within the segment software?
Yeah, there are. So that... Rob's definitely the better person to... Yeah. Oh, yes, sorry. The question was, can we change the reconstruction algorithm within the Siemens software? So here, this recon method, it's the wrong... So the recon method, if you press the arrow, it's got a list of reconstruction methods. The choices I don't think are great. Rob, you can...
Right, so the choices you've got iterative without time of flight, iterative with time of flight, and iterative with point spread function. And there's no downside to putting in time of flight. You're always going to get a bit signal, so always do time of flight. Point spread function is going to depend on the model you scan. The reason I say that is because...
Sorry, can I just interrupt you? I didn't actually explain point spread function. The point spread function is about... So in this slide I said, if that is your object, by recognising that there are some limitations to the scanner hardware and the spatial resolution, then the object is actually blurred a little bit because of the positron travelling and the number of crystal detectors and so forth. The point spread function, it gives the function for what a single point of radioactive decay would create. So a single point like that creates a spatially defined area. So that's the point spread function.
So it tries to do the inverse of that. And the problem with that is that if the inverse of that between the ultimate resolution of the system and the trigger, and it's a big gap, then you're going to end up with a Gibbs artifact around the edge, and you're going to create artifacts in the region. But if it's small, like on a vision, you really upset it. So it depends entirely on how good your scanner is. If it doesn't have to do, if the point spread function doesn't have to work very hard, then it's probably worthwhile adding. If it has to work pretty hard, then it's going to produce enough.
So the rule of thumb, I guess, if you've got a recent scanner with decent spatial resolution, is you'd want it on, and if you've got an older scanner, you would be better off with the point spread function off. Any other questions?
Yeah. So I mean, the other thing is that we talked a bit about segment and picking up making sure that we do things uniformly, right? And giving our reasons of interest right. If everybody in the planet is doing different reconstructions, then also runs into problems. So obviously you want to keep, particularly if you're doing groups of different reconstructions, aim for a high resolution, aim for the best you can do, but if one's an outlier, then you're going to get problems in terms of the quantification of what you do. That's why we're trying to harmonise up to a better resolution rather than smooth down. And that's what we want to do into the future. But it's a solvable problem, published on it. We've just got to get people to adopt it. That's the problem.
Okay, I think we're done.
So at this point, this closes the day. I'd just like to thank Chris and Rob and Katie for their talks today, to Katie and Rob for putting the day together, for Toby for all of his help in making it happen. There's Toby. And hopefully it has been useful. I'm sure there will be feedback sought from you to work out what was useful about today and about how we might improve such an event in the future. So thank you for coming and enjoy the rest of your days.